And to welcome all of us in today's International Nursing Conference, let us hear the message of the Dean of the College of Nursing from Quezon City Campus. Let us welcome Dean Nelia Capulong.
Good morning, everyone. To the deans, faculty members, and students from different colleges of nursing, to the panelists, Dr. Rhonda Laus of Lecturio, Dr. Kyriakides, to our supportive president, all of you, Dr. Caroline Enriquez, and to our esteemed guest speaker, Dr. Patricia Benner, a theorist and author of nursing books. Welcome to the first International Clinical Competence Conference. The present health situation has brought disruption to our daily lives, where we have to adapt and be resilient to a new normal. We used to enjoy face-to-face teaching and learning, but now we do it virtually through various platforms, either synchronously or asynchronously. The pandemic has been with us for almost 1.5 years, and now we utilize flexible learning in teaching our students. This conference is very timely and relevant. A question that comes to our minds as educators is how to develop the expected or required competencies of the nursing students, who will be the future frontline healthcare workers, rendering quality care to the individuals and community. Indeed, we are very fortunate to have a well-known theorist and author of nursing books to talk on the clinical competency development via online instruction. And also with us are the three panelists coming from New Zealand, USA, and Saudi Arabia to discuss the best practices on online instruction. So again, welcome to this conference. Have a pleasant and informative morning.
Thank you very much for that warm welcome, Dean Nelia Capulong from our Quezon City campus. At this juncture, let us now hear the message of our beloved University President. Let us all welcome Dr. Caroline Marian Santos Enriquez.
Good morning, everyone, and my sincerest thanks, Arnel, for the warm welcome and the introduction. Once again, it is my pleasure to welcome all of you, especially my dear students and all the participants, to the first International Conference on Clinical Competencies Instruction during the pandemic. I am elated that today we bring to you a powerhouse full of excellent speakers coming from different parts of the world, virtually. Allow me to express ahead of time my sincerest gratitude and warmest welcome to our speakers, Dr. Patricia Benner from University of California, Dr. Rhonda Laus from Lecturio, our very own Dean Uwayan, Mr. Francis Vasquez, Ms. Jenica Rivero from Southern Institute of Technology in New Zealand, Dr. Ferdinand Gonzalez from University of Hale in Saudi Arabia, and Dr. Bienvenido Tabuzo from Yale University in the USA. We are indeed fortunate that in spite of the trying times, we are able to bring everyone together, albeit virtually. We know that the nursing profession demands that future nurses and current nurses should always have the correct skills and nursing competencies at all times. And this should always be coupled with the value of compassionate care and understanding to all our patients and to all the people who will need our help. This conference intends to impart alternative strategies on improving clinical competencies in online learning, recalibrate our syllabi to make it more relevant, and to learn from other international academic institutions about their best practices on effective instruction and clinical competencies. So my dear friends, my colleagues, my students, from the comfort of our homes and wherever we are situated, we cross the digital divide and bring to you the experts in clinical nursing care. With that, let us all listen intently to our experts, take down our notes, and learn how we can become better nurses now, in the future, in pandemic or not in pandemic, so that we could always show that all nurses care for their patients with the correct skills all the time. Mabuhay po kayong lahat and welcome to our conference. Thank you. Back to you, Arnel.
Thank you very much for that heartwarming message, our University President, Dr. Caroline Marian Enriquez. While the pandemic has significantly disrupted education provision, it has also provided opportunities for transforming pedagogy, new ways of teaching and learning, new ways of communicating, and new roles to increase the overall level of care for student well-being. And here to talk about the resilience during this pandemic, let us all welcome the Dean of the College of Nursing, Professor Dr. Maria Louisa Uwayan.
Hello, good morning, everyone. Can you hear me now?
Yes,
Hello?
dear, I hear
Yes.
you.
Very much. Again, good morning to everybody, especially to our dear President. Thank you very much for giving that wonderful message to all of us and inspiring us always. To our dear speakers and to our attendees, please bear with us as we share with you the world and as we put together and collaborate our ideas together so that we can prepare our curriculum for the coming school year and semester. Okay. So let me share my screen now. Can you see my screen?
Yes.
Okay, thank you very much. So I think I was introduced very well by Dr. Buentamino. Thank you very much. So the outline of my presentation would be more on describing what we have been through and how we became resilient and our future directions with regards to this in our academic and health educational institutions. So I have some disclaimers, no? And this will be focusing more on the general aspect of resilience. There are no conflict of interest. I did this study in collaboration with Dr. Brian Gosson of the De La Salle University College of Business. And this is a study which I conducted early this year with regards to colleges of nursing and higher education institution in Metro Manila. For our learning objectives, I hope that you'll be able to appreciate the value of institutional academic resilience. We'll be able to adopt a resiliency model or framework in our own academic institution and probably apply these principles as part of future-proofing our own HEIs. So this COVID-19 pandemic had revealed our vulnerability, fragility, and susceptibility. But in the same way, it brought us to our humanity. And part of my study, we were able to find out the following. We were all in this together. There were problems and difficulties in connectivity with the limited internet servers, the limited bandwidth, and the volume of users that are connected in the internet in this World Wide Web. There was really a great problem in connectivity. And this problem and connectivity brought us a problem in communication because we are not there physically. We need to communicate digitally. And since we cannot connect, communication is limited. Our curriculum needs to be modified. But how this was going to be modified, there was a great confusion on that. Compensation was limited because a lot of people were losing their jobs. Academic loads were limited to those who can access to internet and blended learning or hybrid learning. There were a lot of difficulties in terms of control. How can we control internet? How can we control electrical powers or outage? These are out of our control. So we are brought to that particular level of who we are as persons. Our humanity is really questioned. Then there was a great confusion. Will there be a tomorrow? Are we going to continue with the next academic semester? So there was a great confusion on this. So these were all the settings that we were in terms of our difficulties. But we keep working, we keep pushing, we keep going on. Why? It was all about balance. We balance ourselves with the demands of the world, our family, friends, education, money, work, and even our love life. It determines who succeeds or not, and it separates the winners from the losers. So this brought us to that particular concept of being resilient. Filipinos are known to be resilient. But what is resilience really? It is a stout acceptance of the reality. This COVID-19 pandemic, there was no manual prepared for this. But we have to accept that it's with us now and we don't know up to when. We have that uncanny ability to improvise. We have so many ways of fighting or preventing COVID-19 infection in our families, in our institutions, and probably within our country. The capacity for successful adaptation. You know, the up and down numbers of people being infected, that was really a measure of how successful are we in adapting to the measures provided by our government in terms of preventing infection. Also, it has to be buttressed on strong values and meaning. So it also integrates who we are as people, our vision, our philosophies, our values. So do we really value life? We value the future. We value one another. According to Richardson's resiliency model, our life is full of so many stressors, but there are also protective factors. And when we are encountered with these disruptions in our VUCA environment, volatile, complex, ambiguous, uncertainty, we tend to be affected in several ways. So when we are affected, we tend to reintegrate. But reintegration would be coming in different features. There would be dysfunctional reintegration. There will be reintegration with loss. Some of us have lost our family member, our loved one. Some will be able to reintegrate to a balance, a certain balance or homeostasis. And some will be able to be resiliently reintegrate and go back and promote growth in their individual capacity, in their institution, and in their community. According to Cantor Isserise in 2015, there are three particular dimensions of organizational resilience. Robustness, which measures the resistance capacity of an organization. Agility is we assess how easily and rapid an organization adapts to the changing circumstances. And integrity looks into the employee's capacity to work together as a team. And in my study, we were able to find out that the most significant factor or dimension was robustness, our capacity to be resistant. Now, with this measure, with this number, we'll be able to focus more on our institutional capacity to be agile and to focus on our people and to work further as a team. So it is really recommended that our institution be measured also in a particular tool of measuring organizational resilience, so that when we plan our curriculum, when we plan our directions as a higher education institution this coming academic year, we'll be able to focus not only on robustness, but also our capacity to be agile, our capacity or increase our integrity as a higher education institution. With this study, we were able to find out that there must be an awareness of our resiliency level, bounce back and respond to our present condition. We need to connect, communicate, collaborate. We need to develop and monitor and review people, protocol, and product, and integrate our ethical compass in this organizational integrity. And we call this are the 5 insights of organizational or academic higher education institution resilience. The study also brought us to realize that with the difficulties, we are now focusing on these directions, the channels of communication, improving other factors that are involved in communication, identifying other platforms, capacity building in terms of curriculum. Will it be a blended, distant, hybrid type of curriculum? We need a lot of re-engineering and recalibrating of this curricular design. And also, we need to increase our capacity in terms of manipulating technology. The competency enhancement of our faculty is also a primary direction, because now faculty are not just facilitators, mentors, or preceptors. Now they are also curators of curriculum and instruction. There is a need to be concession on what and who is on the other side. You know, every day we are faced with this metal framework, this desktop, this hard thing, but we must see beyond. Who is that person at the other side of this window, at the other side of this desktop? There is a direction towards corporate care or holistic care of our stakeholders. We need to take care of those people who are depending on us so that we can always work together for success. We learn to celebrate simple victories, and we need to focus on the simple victories because we believe small victories will lead us to bigger ones. And of course, collaboration. In fact, that is the one agenda that we'd like to introduce also during this international conference. Because we have heard during this pandemic a lot of community pantries. So why not introduce academic pantries, wherein we can all come together in one particular tagline: magbahagi ayon sa kaalaman at kakayahan, makipagdamayan ng bukas ang kalooban in terms of our academic capacities as institution. Because indeed, we are all in this together. No man is an island. It's cliche, I think, but it is true. We cannot survive as our own institution alone. We need to also introduce Dean's Toolkit so that our deans as leaders and administrators, managers of colleges of nursing will have something to look into, to serve as backup for them when things like this happen also in the future, though we don't see the future. That's all, my dear friends, and thank you for listening. If you can find me at mtywayan@fatima.edu.ph. Again, good morning.
Thank you very much for that wonderful presentation, the Dean of the College of Nursing, Professor Dr. Maria Louisa Uwayan. In a joint Memorandum Circular 2021-001 released by the Commission on Higher Education and the Department of Health, guidelines on the conduct of related learning experience of nursing students during this pandemic were set. The Our Lady of Fatima University was one of the higher educational institutions duly authorized to conduct the limited face-to-face classes following the approval of the IATF. And here to talk about preparing for clinical limited face-to-face, the OLFU experience, we have with us our program head and the overall chair of this International Nursing Conference. Let us welcome an alumnus of the Our Lady of Fatima University from BSN class of 1991 and an outstanding alumni awardee. Let us all meet Professor Francis Vasquez.
Thank you, Sir Arnel. Okay. Good morning, everyone, and I welcome you all to Our Lady of Fatima University. So my task for this morning is to share to you how Fatima prepared for the limited face-to-face. The global lockdown caused a great interruption in the students' acquisition of learning. When the pandemic struck last year, academic institutions were compelled to transition from face-to-face to online instruction. Our Lady of Fatima University was one of the higher education institutions in the Philippines that was affected by this sudden shift, and we confidently embraced the challenge. When the community quarantine was announced in March last year, all FU, like other educational institutions, had to respond swiftly to be prepared for online learning. It was not a simple move to shift to fully online classes, even with the learning management system in place. College deans had to review and recalibrate their curricula to make learning more accessible and to pursue more innovative ways to safely adapt to the changing situation. In the transition to the flexible learning, education must continue, and we must all learn from this situation so that we will be able to adapt very well in this pandemic. So as early as May 2020, the university intensified the role of the Crisis Management Committee in developing health and safety protocols. Several meetings were conducted to brainstorm and develop needed policies that would be important for both students and employees. And as early as September 2020, with the leadership of our university president, Dr. Caroline Marian Santos Enriquez, all who started to plan for a possible face-to-face limited classes, because we need to adapt with the new normal. Between October to November of 2020, Our Lady of Fatima University started retrofitting its facilities. We received the joint memorandum circular conducted the self-surveys. We conducted also series of meetings among the top management and middle management. And we were able to submit, compliance report. In December 1, 2020, Our Lady of Fatima University was jointly inspected by IATF and CHED. So the chairperson of CHED, Professor Prospero De Vera, and Secretary Carlito Galvez Jr. Inspected Our Lady of Fatima University. Okay, so on December 1, 2020, we were inspected by IATF and CHED. So this was the inspection conducted by the IATF and CHED. And on January 11, 2021, Malacanang issued a memorandum order on the resumption of limited face-to-face classes for medical and allied health-related programs. And in January 19, 2021, Valenzuela City Engineers Office inspected the Olfo facilities. On January 25, 2021, Olfu, UP Manila, and Ateneo de Manila University were approved to go face-to-face on laboratory courses and hospital-based internships. On March 1, 2021, the College of Medicine of Our Lady of Fatima University started the limited face-to-face at the virtual laboratory. And in May 11, IATF, CHED, DOH, and LGU inspected the College of Nursing, Physical Therapy, and Medical Laboratory Science and were approved to go on limited face-to-face. And the College of Nursing of Our Lady of Fatima University plans to start the limited face-to-face on June 7, 2021. These were the first higher education institutions that were approved by the government to go on limited face-to-face. We have the UP Manila, University of Santo Tomas, University of the East, Ateneo School of Medicine and Public Health, Pasig, St. Louis University Baguio, and of course, Our Lady of Fatima University, Valenzuela City Campus. So what we did as an institution. First, Our Lady of Fatima University conducted series of meeting and recalibration of the curriculum, retrofitting of the facilities, establishment of health protocols, submission of self-survey, actual inspection by CHED, IATF, and the LGU, and we submitted the compliance report to the CHED and IATF. So these are some of the examples of the retrofitting and preparations that the university conducted for the limited face-to-face. Of course, we established our own community safety policy for the students, employees, parents, and visitors who will be going in the university. So this poster is placed at the main entrance gate of each of the campus. So the walkway or the corridors were, we put some signages and direction, okay, because we need to do a one-way movement or one-way flow. And also on the right of your screen, this is the elevator at the right tower of Fatima University, wherein the elevator can only accommodate 4, including the operator, and each passenger of the elevator must be facing a corner. So naka-back-to-back sila. So for our basic nursing laboratory, because the College of Nursing has 2 types of laboratory. So we have your Nursing Arts Laboratory, which is located at CAS building, 4th floor. So this is our basic laboratory wherein our nursing students are being trained before they will be allowed to proceed to the virtual laboratory. So we retrofitted our Nursing Arts Laboratory wherein it can accommodate only 10 students per room. Okay. And also, this TV monitor is hooked to the other TV monitor of the classroom, wherein what is being viewed in this particular room can also be viewed in other rooms. So that therefore, all students who will be staying in 4 different rooms will undergo the same clinical scenario or the same discussion being conducted by the faculty members. So in our nursing arts laboratory, we have 4 amphitheater type lecture demonstration room, and we have 2 return demonstration rooms. So for example, this is one amphitheater type lecture demonstration room. Okay, on the far end of this area, we have another lecture demonstration room. And between the 2 lecture demonstration room, we have the hospital type cubicles. We have 4. And this is also equipped with a nurse's station. Okay, kaya through and through. Okay, so at the entrance of each room, okay, it is indicated that the number of persons who are only allowed to occupy this room. So for example, here, 14 persons are only allowed inside, including the faculty, including the laboratory technician. Okay, so alcohol is also provided at the entrance of each room. Okay, so health protocols, wearing face masks, face shields are all visible at the main entrance door. And what we did at the College of Nursing. So number 1 also, we conducted several meetings and we had this catch-up plan. Okay, so the limited face-to-face is part of the catch-up plan. Setting up of virtual laboratory and nursing arts laboratory, Zoom meeting, and we also conducted orientation with the parents and the students about the limited face-to-face classes, planning the RLE schedule and activities, COVID-19 training among faculty and students, and the plan for the vaccination. Now, this COVID-19 training among faculty members and students, the Our Lady of Fatima University College of Nursing tied up with Project Hope, Assist Philippines, which is also tied up with Watson Institute and Brown University, wherein all faculty members of the College of Nursing were trained as trainers for this IPC, okay? Management for Filipino Healthcare Workers, okay? So we are certified and we are rolling out, okay, this training to our students. Actually, we are already done rolling out this training. This is a 3 to 4 days training because this is composed of 8 modules and there are post-tests being answered by the participants. So this rollout began with our 4th year. We are done with the 4th year, 3rd year, and currently we are doing the rollout of this training for our 2nd year, and for the 1st year students, we will conduct it in June. Actually, we invited several nursing schools to join this training. We have Holy Angel University from Pampanga. We have St. Paul Duguete, okay, Nueva Ecija, NEUST in Nueva Ecija, and other schools. Emilio Aguinaldo also joined, okay, in this particular training. And all the students who finish this also receive certificates from Assist Philippines. So this is the sample of the limited face-to-face RL schedule that we are going to implement. Okay, so for example, we are following the 410 scheme. Okay, so what is a 410 scheme? So students and faculty members will only report to the university for 4 days, and they will be on quarantine or stay at home for 10 days. Okay, so for example, for groups 1, 2, 3, 4, and 5, they will undergo the limited face-to-face at the virtual laboratory or our basic nursing laboratory from 8 a.m. to 12 noon. And then the second batch, groups 6, 7, 8, 9, and 10 will come at 2 p.m. to 6 p.m. In between the schedule, between 12:30 to 1:30, all classrooms, all the laboratories will be disinfected. So there is a time okay, to conduct disinfection. So after these 4 days of limited face-to-face, these particular groups, groups 1 to 10 will go online during the 10-day quarantine period. Okay, on this 10-day quarantine period, June 14 to 17, a next batch of students will be fielded in the virtual laboratory and nursing arts laboratory. So for example, group 11 to 15 for morning class and group 16 to 20 for the afternoon class. Okay, so the cycle will go for a minimum of 4 weeks to 6 weeks, okay, for us to be able to develop clinical skills, okay, during the face-to-face. Now, to help us during the face-to-face, limited face-to-face RLE, it's good that our administrators invested a lot, okay, for for the virtual laboratory facilities. The virtual laboratory is located at 7th floor, Rice Tower, Research, Innovation, Science, and Enterprise Tower. Okay, so we have a wide array of mannequins, high fidelity mannequins. So on your screen, we are going to utilize Apollo, okay, for our adult nursing. He is hooked in the computer wherein we can manage his health condition. So pwede magkaroon ng unilateral rise in the chest. Okay, for example, if there is pneumothorax, pleural effusion, or thoracic injury, etc., etc. We also have Lucila, our OB model, our pregnant model, wherein she can actually deliver her baby. It could be cephalic presentation, bridge presentation, and the students get to appreciate an actual fetal heart tones. They can auscultate the actual fetal heart tones, and they can feel uterine contraction, okay? And they can also see the vital signs, the changes in the vital signs of this particular model. So our virtual lab is across lifespan. So we have a pediatric simulation mannequin, okay? So what can be done with Apollo to the adult mannequin can also be done in this pediatric sim model. We also have the newborn, and this is the Billy Light. This is functional, wherein students will be able to be trained on how to use the photo of the Billy Light and how to manage a baby with jaundice or hyperbilirubinemia. We also have task trainers mannequin for IV therapy and blood transfusion. We also have SAM, auscultation SAM, wherein students will be trained, okay, how to auscultate anterior, posterior, listen to breath sounds, heart sounds, and bowel sounds. Okay, so as you can see, we have a wide array of different mannequins or patient simulators. Okay, so we have the basic mannequins wherein students can actually insert NGT, okay, perform gastric lavage, gavage, catheterization, and other procedures. At the middle section of this slide, we have the area for the faculty members. Okay, so for example, this one-way mirror can see this particular side of the virtual laboratory, and on this side, they can see this other side. Okay, so that during the return demonstration, the students will not be conscious, okay, that they are being graded by their respective faculty members. Okay, the virtual laboratory is also equipped with operating room. And we also have these basic task mannequins, okay? Now, to help us also in this online learning and also for the limited face-to-face, we will be using, starting this first semester, Lecturio, okay? Later on, our guest speaker will discuss a very distinct and very special program, okay, that Lecturio provided to the College of Nursing of Our Lady of Fatima University. So thank you very much, and I welcome you all to Our Lady of Fatima University.
Thank you very much, Professor Vasquez, for walking us through your preparation regarding the clinical limited face-to-face. To our attendees, please feel free to use the Q&A button located at the lower portion of the screen. You might wish to ask questions to our speakers, and we will have time later for this during our open forum. We will now move with the highlight of this international conference. It is an honor to introduce one of the pillars in the field of nursing. We are honored to have her for the first time in the Philippines. Our speaker is a professor emerita at the University of California School of Nursing. She is a noted nursing educator and author of From Novice to Expert, Excellence and Power in Nursing Practice, which has been translated into 12 languages. She has directed over 50 doctoral dissertations. She pioneered the use of interpretive phenomenology in nursing. She is the director of this Carnegie Foundation for the Advancement of Teaching National Nursing Education Study, Educating Nurses, a Call for Radical Transformation, which is the first such study in 40 years. Additionally, she collaborated with the Carnegie Preparation for the Profession Studies of Clergy, Engineering, Law, and Medicine. Our speaker is designated as a living legend of the American Academy of Nursing. She was elected an honorary fellow of the Royal College of Nursing and Danish Society for Nurses. Her work has influenced beyond nursing in the areas of clinical practice and clinical ethics. She has received 2 honorary doctorates. She is the first author of Expertise in Nursing Practice, Caring, Ethics, and Clinical Judgment, published in 2010 with Christine Tanner and Catherine Chesla. And she has co-authored 12 other notable books, including a second edition of Clinical Wisdom and Interventions in Acute and Critical Care, a Thinking and Action Approach. She is the executive director of educatingnurses.com and co-founder of novice2expert.org. Dear colleagues, ladies and gentlemen, our keynote speaker, please welcome Dr. Patricia Benner.
Mabuhay. I am so delighted to join you, and I'm very excited about all the panelists' presentation and the presentation we just heard, because COVID, while it's been a cauldron of challenges and difficulties, has also been a cauldron for innovation. So I'm going to share my screen. I want to talk today about the ways of teaching clinical reasoning during this time of COVID, where we had restrictive clinical placements. I'm having trouble getting my slide to advance, so I need a little technical help. I don't know why it isn't advancing. Oh, here we go. One of our major issues prior to the COVID pandemic was addressing the education practice gap. We have a huge education practice gap that nurse educators are really struggling with pre-pandemic, but now even more, this gap has widened during the limited clinical placement during the COVID. And I have, as one of your handouts, this article from Stanford University by Garrett Chans and Burns on quantifying the new graduates. You see in the red, these are all pre-test scores prior to doing the online simulation, NOVEX. If you notice here, this is acute coronary syndrome. Only 8% of the graduate students who had taken their NCLEX exam passed. And then after doing NOVEX, 94% passed. One of the alarming areas we found was that this very low pass rate among patients with strokes. And we found a common misunderstanding on the part of the students was that they really didn't distinguish between occlusive strokes and hemorrhagic strokes. And so they did disastrous sentinel event kind of interventions. We did capture all of the sentinel events prior to doing NAVEX. And then you can see by doing NAVEX, this online simulation, they really were able to dramatically decrease sentinel events. We'll go into the analytics and the sources of errors a little bit later. In the Carnegie study, we looked at the 3 universal professional apprenticeships, the knowledge, science, theories of the profession. And I must say, this is the apprenticeship, and by apprenticeship, it means you have to have instructors who can guide you and point to areas of practice that you can't navigate on your own. But the strongest area of teaching is in this cognitive apprenticeship, this knowledge, science, theories of the profession. We are weak in the area of practice apprenticeship. So the cognitive apprenticeship has to do with knowing that and knowing about, knowing what, but knowing how and when, this situated thinking and clinical reasoning across time. We demonstrated in the Carnegie study nationally in the US, we were doing very, very poorly in this area, and that continues to this day. The third apprenticeships, these apprenticeships are all intertwined, of course. And the third, ethical comportment and formation, learning to embody and enact good practice in specific situations, is the most integrative of the apprenticeships, because you require the cognitive and the practical apprenticeship in order to have good ethical comportment and formation. So in fact, all of these are very much intertwined. One of the findings of the Carnegie study is that we are doing most poorly in teaching clinical reasoning in schools of nursing. And by clinical reasoning, we mean reasoning across time about the particular through transitions or changes in the patient's condition and or the clinician's understanding or new recognition of the nature of the situation. And we are currently using the nursing process model of teaching nursing clinical reasoning, but it is the poorest model we could possibly choose. And I'll explain a little bit more about that. I am recommending Dr. Tanner's, Christine Tanner's model of clinical judgment because it includes perception. Notice this, noticing. Because prior to assessment comes the ability to perceive and notice, have a perceptual grasp of the nature of the clinical situation. And notice all clinical reasoning is across time. So you're looking at trends and trajectories. And this, and you're analyzing what you're understanding, what your interventions are doing, and then you are reflecting and altering your interventions. And what we found in the Carnegie study is that we simply aren't teaching clinical reasoning. The nursing process is an analog to the scientific reasoning process. It's linear. It's about snapshot or formal criterial reasoning to make absolute yes and no decisions. But these are all at points in time. So you might call it snapshot reasoning or a slideshow kind of reasoning versus a moving picture, because you're not getting transitions across time. We should not be using nursing process to teach clinical reasoning beyond the first quarter or first semester in nursing school. And part of that shows up in this distinction between practical and theoretical knowledge. We do a really pretty good job of theoretical knowledge, knowing that, knowing what, knowing about, for example, neurological development, even growth and development, need for stimulation, and the hazards of immobility, family. I could go on with all of our content. We do a good job of that. In the US, we're really focused on concept-based curriculum, which is both a strength and a real limitation, because this side, skilled know-how, situated thinking, this knowing how and when to act, that is more than mere application of knowledge. It is every bit as productive and higher order knowledge as any theoretical knowledge. So, for example, the example I like to use is teaching someone a blood pressure, which to take a blood pressure you can do in 10 minutes, and application of that is, can they measure the blood pressure? But for skilled know-how and for knowing how and when, for the productive use of knowledge, you have to understand the meaning of the blood pressure for the particular patient in a particular context and across time. For skilled know-how, students must learn, and in fact, you can never be proficient or expert if you don't develop a sense of salience, where some things just stand out more or less important than others. Also essential for developing expertise is the development of skill of engagement, both with the problem of the clinical situation, but also with the patient and family. Perception, we've lost about 30 years of good pedagogical work in academia because we've been so focused on information processing models and the computer model of the mind and cognitivism. But those days are over in neuroscience of learning. We now really are seeing how important perceptual grasp and acuity, the skill of seeing, really is to any clinical person, including physicians, lawyers, social workers. One of the essential parts of situated thinking is recognizing the nature of the clinical situation. And then the other aspect of learning any practice discipline is experiential learning. But we've been so heavily focused on theoretical kinds of transmission of knowledge, we've shifted experiential learning. Experiential learning always involves a turning around of preconceived notions or pre-understandings. Or it means that you suddenly see what you don't expect to see. For example, in the recovery of a patient from open heart surgery or the progression of a labor and delivery. Experiential learning is the only thing that will allow you to get this fluid perceptual grasp of the nature of a whole clinical situation. And it requires openness and responsiveness. So one of the key roles of the situated coach, the faculty, is to teach students to give public language, to articulate their insights about experiential learning. In fact, one of the most interesting things in the Dreyfus model is once the person moves into that proficient stage, you get all of these turnaround kind of narratives. Well, I went in thinking this was going on, but that wasn't what was going on. Something entirely different was going on. And that's this openness and responsiveness to learn directly from experiential learning. As a faculty member, I implore you, please don't always have your students translate experiential learning into a concept map. Let them first articulate what they've noticed, what they've perceived, and they may be noticing something that isn't yet well defined in concepts. It may be pre-theoretical. So taking seriously and valuing experiential learning is essential to teaching clinical reasoning. So the first year of education, of course, the student comes with little or no experiential background understanding usually. And so the faculty has to teach in terms of formal attributes and features that can be described and recognized. If the blood pressure is over 140, this is usually too high. You give rules and maxims, but of course, these are all always need to be particularized, but you can't do better for the novice. You have to give them rules and broad guidelines to organize their task world. That's why that nursing process for just organizing and cataloging information is quite useful for the novice. The novice is busy matching actual cases with textbook descriptions, with lists of signs and symptoms. So what the teacher must do for the novice is fill in that missing perceptual grasp. They, of course, have no experience multiple futures. And they also need coaching about the nature of the whole situation that has, that includes in it a sense of salience. Well, you know, in this situation, we're really wondering, is this heart pump failure or is this volume depletion? So this kind of narrative, interpretive understanding of the nature of the whole situation, what are the stakes for this patient clinically in this situation? And you want to promote narrative memory of these whole concrete clinical situations. Because eventually that's where every expert clinician must go. Both in medicine and nursing, we have research showing that experts literally walk around in past whole concrete cases. They remember the 12 pulmonary emboli cases they've seen, and that's much higher fidelity for perceptual recognition than a list of signs and symptoms from cases. So as teachers, we have to teach our students to revere their perceptual grasp and what they notice in actual whole concrete situations. And I'll show you how we translate that into the pedagogy in NOVIX. So the instructor's job is also to help the student cope with proliferating variables, how impossible it is to make everything explicit and formal formally stated in practical situations, because they're always too multi-layered and too complex to list every relevant element in the situation. It's impossible to make all aspects of clinical situations completely explicit. I lived through the heyday of behavioral objectives. And finally, by the senior year, we had 800 at UCSF, 800 plus behavioral objectives. And that's a really great example of the limits of formalism. Eventually, you have to come to a way of conveying what's at stake, what's most urgent, what's most salient, what's highest priority. So understanding the meaning of the clinical situation becomes essential. So you have to move from an old-fashioned artificial intelligence where you build the situation up element by element. That failed, it doesn't work, to a much more fluid neural net learning where you learn from success and failure. This is also a movement, and this is the new current neuroscience of learning movement, a move away from a representational view of the mind, where you imagine that all thinking occurs as a result of ideas, templates, schemas, concepts. While the mind can work at that level, that's not the most primary or most frequent. It overlooks the kind of direct immersion and learning from practical situations. Often you don't have preconceptions. I remember thinking this application when our space travelers noticed all the spirals in the ocean. Well, they weren't pre-programmed. They didn't have concepts to know that those spirals were there, but when they saw them, they recognized them. And that's that direct immersion. And it's also neuroscience attentiveness to realism and direct apprehension and experiential learning from practice. So the faculty has to coach the student to have a sense of salience. Well, in this situation, what's really at stake here is to make sure the patient doesn't go into pulmonary edema. And this is the pattern that's been there before. You offer a sense of salience, and you teach according to urgency and priority through coaching. That's how you learn clinical reasoning. You also coach students to develop an unfolding narrative about the changes across time. And trends and trajectories are everything when it comes to clinical reasoning. The advanced beginners are really at the senior or new graduate level, and they have special learning needs. They're still very caught up learning to mechanically work things, to do skilled actions, inserting IVs, inserting Foley catheters, whatever. So their temporal focus is on the immediate present. And they often have to say, well, you know, does this look like too much wound drainage or too much blood? They don't have any comparisons, so they need to ask other clinicians for comparisons. What's wonderful about the advanced beginner is that they're beginning to feel their agency, their responsibility, but they're always limited in forecasting what might happen next or recognizing an early warning, because they are so limited by the futures they've actually observed. So they rely a lot on protocols by necessity. But I seldom think you find a more engaged learner than that advanced beginner. They're beginning to see what they don't know. They're beginning to understand that they have to develop a perspective, or the situation is just too complex and it ends up with them proliferating variable after variable without being able to tell what's most important and least important. The advanced beginner has to really understand and begin to evaluate the patient's discomfort. And that only comes from direct clinical experiential learning. They're very busy establishing boundaries with what they can do, what they can offer, what they can't offer. They often are dealing with some of those pathologies of perhaps wanting to be the omnipotent rescuer, and then recognizing, no, this isn't something I can help with. They're very busy looking for credible sources of information because they need someone on the spot to ask all these very local specific questions. I think the only reason you survive as an advanced beginner is you have a kind of secondary ignorance or a cushion of inexperience. You don't know what you don't know, and that's the only thing that keeps you plugging along. But the task world, the assignment is really perceived and experienced as multiple competing tasks, because there isn't that sense of salience of something standing out more or less important. And the advanced beginner is busy matching examples with textbook accounts. And this is the beginner. This is not where you want to land. Where you want to land is to have enough whole concrete cases that with high fidelity, you can compare maybe the 5 patients with pulmonary embolus that you've seen, or a patient with pump failure or whatever. So for your teaching and learning strategies with advanced beginner, that senior or new graduate, is situated coaching with teaching that advanced beginner to develop a clinical grasp of the nature of that whole clinical situation. You're trying to, and this is what we do in NOVEX, is to help them focus on early warnings about changes in the patient's condition. And also, local, practical, and organizational knowledge that just doesn't come even in the procedure books. You try to fill that in. Well, if you want to get a physician's order, you know, on this unit, you have to do it between. All of that sort of practical knowledge you can coach the advanced beginner about. And you can introduce them to planning sheets for care and organizational time management strategies, because the primary way they reduce their stress at this point is through time management, because they're so overwhelmed with the time it takes them to perform. So now I want to introduce you to this online simulation program that my colleague, Pat Kirikides, is going to help me talk about. We have a 13-year history of research and development using this novice to expert Dreyfus model of skill acquisition, but also the Carnegie research on what we're not teaching well in terms of practice readiness. We're also very keen on the current neurobiology of learning, which is really showing us that a representational view of all learning is just too narrow and doesn't capture perception well enough. Also, the importance of active, engaged learning, where the learner is the agent and has to take responsibility. We also emphasize evidence-based practice guidelines where they exist, and where they're absent, we emphasize that. So we are trying with this online simulation program that I'm going to demonstrate, trying to create authentic learning with real patient responses. There are no fabricated cases. And if there are data missing in the case, we don't fabricate it, we don't put it in, because that's real life. We've developed all the cases collaboratively with clinical and academic experts, nurses and physicians. And we have proven performance outcomes. And I've given you handouts on the Chan and Burns article and Johnson and Crumlett article on showing the impact. For example, in the Johnson and Crumlett article, they had in 2 hospitals a 40% more morbidity rate from sepsis. And by introducing the novice sepsis model, they reduced that very first year from 0. So take a look at the Johnson and Crumlett article, because it shows you how effective a pedagogy is that focuses on early warning, because with sepsis, the only way you can save lives is if you catch it early. The online program, of course, is scalable for everyone. I'm not going to spend very much time on the lessons, but I could spend an hour. I love the way the lessons work to never leave it to that novice's clinical imagination for what the implications are in context for what they're learning clinically. So it's, the lessons are set up based on clinical reasoning of expert clinicians and the clinical context and implications for whatever is being taught is always included. So the so what, the in order to, for the sake of what, that students get the main evidence-based treatment for pneumonia. I mean, this particular lesson we're going to show you is about pneumonia. And then they get the latest evidence-based practice, and they also get both the medicine and nursing roles there. And then we use an algorithm, because all the way through NAVIX, we're teaching for urgency and priority. So they can get a right answer about patient education, for example. But if they haven't administered antibiotics yet, they will get, this is a good thing to do later, but there are more urgent needs. So we really do teach for urgency and priority. And now Pat's going to come on with our online program to demonstrate the interactive nature of the program. And Pat and I will kind of kibitz and dialogue as we always do.
Yes, yes. Thank you, Patricia. Welcome, and thank you for letting me contribute today. So I've taken you onto our NAVIX, Novice to Expert.org site, and you'll see I've got way too many courses and progress bars, but so this would be like a learner's progress on their particular clinical courses. And so you can see that the green would mean that they're passing, the red would mean that they're failing or having sentinel events. Now, Patricia, do you know if sentinel events translate across the world? I just know them from the US.
Yes, what sentinel events are events that are life-threatening or extremely dangerous to the patient, and they're clearly identified by the American Hospital Association. I'm sure you have something equivalent in the Philippines.
Yes, I'm guessing so. So our hope is that a student will be serious and go back and re-enter these cases and learn how to safely care for patients. So let me take us into the pneumonia site. And so when we enter the pneumonia site, it's in a particular course, you enter, there's a tutorial so people can see how to navigate in this particular program. And this is where Patricia grabbed the lesson. So there's many aspects to this lesson. She just showed you a few things. But the most important thing, I think, and what students love about these lessons is that they were developed with clinicians and academicians so that we have set the student up for clinical thinking and reasoning. And therefore, the cases flow right out of the lessons. So let me take you into one of our cases. Patricia presented Miss Butler, so we'll go in and take a look at Miss Butler. When you enter the room, and let me make this a little smaller, when you enter the room, you will get an introduction to the patient, a summary, like a report. And so from that, students may get a hunch about what's going on, but it gives them information that a patient would give in their current chief complaint. So when they exit that, they're in the room. And Patricia, do you want to talk about why there's no guidelines here?
Yeah, there are no prompts. The student feels the same way that they feel as a beginning nurse or as a student. They have to figure out what to do. There are no prompts, there are no questions, and we don't even offer doctor's orders because we don't want to guide their thinking, because they have to be able to evaluate physician orders. So we just tell them that they have all appropriate medical interventions ordered. And this really teaches, which they're legally responsible for knowing when they have a good a safe medical order or not. So this is it's an unprompted case, but this is the only way we can figure out how to teach clinical reasoning. So there are hot spots in the room that we encourage the student to use, because it keeps this embodied orientation to what actions they would take and where they would find what they would need in the room.
Thank you, Patricia. So you'll notice when you enter the room, the patient looks real. We do not use avatars, cartoons, or drawings, because we found the engagement is so much more, the student feels the responsibility, the weight of the care of the patient. And then you'll see we use real rooms. So as they go through and navigate, you'll notice nowhere is there a prompt, as Patricia said, because we know that if you ask a question, you've already done the thinking for the student. So if you ask the question, you can't really teach someone clinical thinking and reasoning. They must learn it, and they do that through problem solving. So hopefully they will solve this case using two major factors. One is everything you've taught them. So they may listen to the patient. Although this is accurate in terms of what the patient said, we may have abbreviated some of these things. We provide them information that is objective. They have to determine what is relevant, and then they've got to keep track of it and make sense of it. When they go on to the monitors, they will have information that this patient had at this point in time. You can see that if the information is abnormal, they have to decipher what it is and what it means. They have to prioritize the information and take action. So they may then go into the EHR. They may look at the IV pump to see what's going. If they go into the EHR, this person was just admitted, so she doesn't have any clinical notes yet. We can see her demographics and so learn more about her. We may go into the diagnostics, and in the diagnostics, which aren't coming on, oops, it looks like I froze. Oh, there we go. Sorry, there's a delay. So they can see, is there any information that may be relevant to what they're needing to think about? And so you can see that this patient had, and they would need to figure it out, an infiltrates in their lower lobes bilaterally, and then they have other information that would be concerning. So they would go ahead and maybe go through the labs. If the patient got labs, as Patricia noted, we give them. If the normals are available on the chart, we give them. If they're not, we don't. They have to find them. They have to know them. They would be able to look at the labs. And for an astute student, this patient has a source of infection. They have at least 2 signs of SIRS, right? And so they also have, if you notice in their labs, they also have multiple signs of SIRS, which would, if they're astute, make them think about sepsis, not just pneumonia. So in this particular situation, you can see that we also, they also got a lactate level to help them understand that they're septic, but not in severe sepsis. So anyway, they can make sense of this as they go through. With the medications, they usually have what is on what the patient was on at home, and they can see what the patient has already been given once they're in the hospital. As Patricia pointed out, because they already have all the HCP orders, the medical orders ordered, then they would go ahead and implement those. And as you would know, they have to SBAR here in the States, make a recommendation, so they would need to be able to do that. In the EHR, they also have the electronic health record. They also have the medical history so that they would have all the information they would need to be aware of allergies or any other complications. So after they figure out what's going on, sorry, I'm having a little trouble with freezing. They would go, and if you noticed, there is a problem, and it is the most urgent problem that they need to take care of. And so, for instance, once they learn the functionality, there are no instructions. So they would go and they would provide oxygen. You see that she's already on 5 liters, but we would need to increase that. Notice that if they do something that's correct, they get a very brief congratulatory message. If time matters, they get information about time. Our hope is that after they do an action, and your hope is they will go back and evaluate the patient. So there's nothing to say whether this is better, worse. They have to know what the normals are and know whether or not this is sufficient, which in this case it is. So the next most important thing that the nurse would need to do would be to give an antibiotic, or because the patient is not on an antibiotic and is infected and is septic. So let's just say that if they wanted to do comfort care, or let's say their patient education, it would be appropriate. But the problem is the timing. And so if they taught good hygiene, it is a good choice, but there are more urgent priorities. And so we nudge them along in their thinking. So we would want them to go to the medication cart. And Patricia, do you want to talk about why this medication cart holds particular importance in our build?
This is a very powerful way to teach pharmacology and medication administration. So they have to look at the right category, which in this case are anti-infectives, and they have to look at antibiotics. And then they're going to have to make a decision on whether to give that by mouth or IV or IM.
I double clicked it and made a mistake. My apologies.
Okay. So she decides to give IV antibiotic, which is a good choice. But now you see 24 hours have passed. And so you can, the student will be able to look at the impact of the antibiotic on the patient's condition. So listen to the patient, and she will find the patient says, I'm feeling better today. When can I go home? And then vital signs, the temperature has improved, fever is down to normal temperature, and the blood pressure has also improved, and the oxygen saturation has improved. So this is 24 hours, and notice how this is all teaching reasoning across time and realistic time lapses for finding changes in the patient. But what I wanted to say about medication is that one of the things the students say, you know, I learned more about pharmacology and giving medicines from NAVEX than I've had any other way, because it's always a particular case, and it's always a particular time frame, and the route matters. So it's a really great contextualized way to teach pharmacology.
Great, thank you. Yes, and so you'll notice that I'm clicking around as if with ease, because of course I know the answers. But the thing about it with students is they don't know, and every click is a clinical judgment. It's clinical thinking in progress. Now, I'll take you back through that. I'll come back to that issue, but notice then after the patient is stabilized, then they may want to go in and do comfort care. They may want to provide, you know, alternating periods of activity if it's appropriate. then we will, then it messages the student that that is a correct action, and so on. They may want to go in and do patient education. And you'll notice now, if we do the same thing that we did before, now the timing is appropriate and we give them a congratulations so that they learn the priority in the care that they give. And literally, every patient is programmed with hundreds of interventions based on the particular situation for this patient. So for instance, if they go in and they want to do safety measures, we have and track never events that should never happen. And you probably do too. And so we literally have all kinds of things. If she's bedridden and she's elderly, then we would want to prevent pressure sores. We would want to prevent glycemic events, etc. So you literally can see this, the student can experience what it is to thoroughly care for a patient. So at the end of their care of this patient, then they would, it's a clinical judgment to determine when the patient's stable, when you're finished, and you would finish the case. Now, let me just show you what might happen if the patient was hypotensive and it wasn't appropriate to give, it was appropriate to give fluids, but not, let's say, a vasopressor. So if you give something that should not be given at the time, then let me show you what happens. This is a sentinel event, what we call a sentinel event. Patricia, would you like to talk about why we throw the student out of the case?
Because we want that maximum learn by failure. It's safe, but the students take it extremely seriously and they don't forget it. They remember their sentinel events, and they really drop down in the program because they're so, they want to avoid sentinel events. Thank God. You wouldn't want nurses who didn't want to avoid sentinel events.
Right. And so they can go back, and you want to talk about why we've set it up so that the students can re-enter these cases over and over again, whether they failed and come back or whether they come back multiple times over time.
Yeah, and maybe this would be a good time, I know we have to kind of move along, to look at the click streams, because you can really see the students' pattern of learning by the choices they make. And so you can diagnose it, you can really literally diagnose where their clinical judgments are faulty or misinformed.
So this is a pretest with new graduate nurses who have passed the NCLEX. And so this is what we're seeing across the US in terms of preparation for practice readiness. And you can see in case after case after case. And what's striking is that on the cases that they're failing, these are our readmissions, or sepsis, of course, is the #1 killer in hospitals, in American hospitals. So if you click on one of these, you literally get what we call a click stream. It means every meaningful click that the user makes in one of the cases, like I just did, you get we track and post for you what they were thinking, what they were doing, the judgments that they made, so that you can see the problems that occurred. And you can see at the very end, she gives epinephrine, which creates a sentinel event. Now, so these are what we call click streams, and those are available on every one of the score tables by clicking them. Now, another thing that I want to go into is on our analytics. So for the faculty, we provide what we call performance analytics. When you go in there's a setting, and you go in and you'll see them, I've timed out, sorry. You'll go in and you'll see that there is a setting for the managers, and you simply click the managers to change roles. And when you do, it puts you into a different setting. So I'm going to take you into a particular one that I wanted to show. So when you go in, if you have a cohort or several, you'll see that cohort's progress as a group. If you click it, you'll be able to see the progress of every student that you've assigned cases to. You'll be able to see whether they did well, whether they re-entered and retook it. If they failed it, you'll be able to then click each student's progress and go in. You'll see every case that they've taken, how much time they spent, whether they passed or failed. You can see how many times they've gone into each case. And I wanted to show you a particular one. This is someone who went into a particular case. She fails. You can see, and we're color coding these to help you recognize when they pass or do something that's good. And when they make a med error, you'll be able to start to see that. And you'll see that she goes back in a day later and passes the case. You'll be able to see that she goes back in a day after that and passes the case again. So you see that this is a more serious learner. And then she goes back in 3 days later and she passes the case again, but does this very extensive care of the patient. So you'll get not only what your students are thinking about and how they go about their reasoning, and you literally can see what Patricia talked about in the novice versus the beginner versus the competent nurse. Based on Patricia's research, you'll be able to see that progression in these click streams. So go ahead.
We're like 2 minutes out, so we
okay,
have to wrap up.
Stop. Okay.
Okay.
Let me stop sharing.
Okay. And I just had one more slide, I think, to really close this presentation down. So our point is that by this online simulation, you can use it with your skills lab. You can use the cases in the skills lab. You can use it also with the diagnostics to group students who have similar learning issues, say they really don't understand stroke, then you can get them together in group learning. We found that through the COVID, for example, University of North Carolina and UCSF are using NAVIX as a bridge from that classroom knowing that and about lectures to the knowing how and when bridge. And it makes the student much more effective in their clinical practicum. So what we're, in conclusion, recommending is that we really limit the nursing process to that first year nursing student, that we really begin teaching clinical reasoning around sense of salience and reasoning across time about particular patients. And we strongly recommend using multiple whole, similar and contrast cases, because research in medicine and nursing now have demonstrated it's the multiple cases of direct experiential learning that create expertise and mastery. A list of signs and symptoms are just pale in terms of fidelity and for clinical reasoning compared to past comparable whole cases. You hear nurses say, well, remember that this baby looks like Jimmy, who didn't tolerate his ductus or patent ductus arteriosus. It's that kind of direct clinical comparisons. And the NAVIX program is designed to teach early warnings and also for most urgent and high priority, and to teach for that sense of salience. So if you have other questions or want more information, please feel free to contact me. I'll look forward to the questions. Thanks.
Thank you very much for that presentation, Dr. Patricia Benner. The information you shared surely will help us in our undertakings as educators during this pandemic. Likewise, we would like to acknowledge also the help of Dr. Kyriakidis. Thank you for walking us through that Novex. We will have Dr. Benner answer some questions later during our open forum. So again, for the interest of everyone, you may use our Q&A button for this matter. Again, thank you very much, Dr. Benner, and to Dr. Kyriakidis. Our next speaker finished her BSN from Southern Nazarene University, and she holds a master's degree in administration from University of Oklahoma and a doctorate in philosophy major in educational psychology from Oklahoma State University. Our speaker started her nursing career in the critical care units of the St. Francis Health System and held positions as a nurse leader in that system for over 15 years. She transitioned to higher education in 2005 and earned the rank of assistant professor at the University of Oklahoma College of Nursing, where she received numerous teaching awards and was a course coordinator for multiple campuses. And one of her goals is to help nursing students increase their level of understanding of the toughest concept in pharmacology and medical surgical nursing. She is teaching students how to use the science of cognitive learning to maximize their study effectiveness. At present, she is the director of nursing programs of Lectorio, a leading international e-learning platform for medical video education, serving students as well as universities and medical institutions. Founded in Germany's historic publishing center in 2008, it has advanced to become one of the major players in the e-learning market. Ladies and gentlemen, let us all welcome Dr. Rhonda Loss.
Hello, thank you. It is a privilege to be here tonight. So I am looking forward to getting to share with you a little bit about what I felt like going through with the pandemic. Now, if you'll let me know, can you see the screen? Is that okay? Oh, did I get?
Yes, but we cannot see
Yes,
you.
Dr. Loss.
Okay, thank you very much. All right. So I am going to start my video so that we get everything rolling. All right, good evening. Hey, if you would do me one favor, I know there is a lot of us on the phone call, but talk to me about what it felt like for you. Just one word. What was your overwhelming feeling while you were going through the pandemic with that teaching? And what was one word that really made you what you felt like trying to meet all the needs of your students? So I'll check our QA and see what we have. Yeah, very cool. All right. Well, I felt extremely overwhelmed with what we were dealing with. And oh, well, there's the whole presentation right there. We're having some technical difficulties, it looks like. Wow. Okay. Well, if you can still hear me, I will keep talking, and you know, sometimes technology is with us and sometimes it is not. So let's see. All right, that's just classic. Well, what I want to talk to you about is, I love what Dr. Benner said about teaching for salience and helping students really become engaged in their learning. If you'll be patient with me for just a second, we'll figure out what's going on here with the technical stuff, and we'll see if we can reset. But as you were thinking about your experience, I know that I was teaching in a traditional nursing program, and I was not prepared to go completely online. Most of our courses were obviously just like yours, that were in person, and they were face to face. So when we had to go, I found out that we were going to be going out to all online, just like you guys did, at the last minute. So it was definitely, we would call that Mr. Toad's wild ride here. Well, this is classic. Okay, let me close out on that and we'll see why we're having a problem. You know, I think I'm going to ask, you guys have a copy of my presentation? maybe we try it from your end and see if that would be better. I'll just keep talking and sharing until we can kind of get a feel for if you guys can pull that up. I sent that to the dean. So if you wouldn't mind doing that, is that acceptable? Are you still there?
Yes, Dr. Laws.
Okay.
We request assistance from our technical committee.
Yeah, maybe. Well, now it's going to work. See,
All
it
right.
just knew when you came on.
Thank you, Dr. Laws.
Well, stay calm. Isn't that what we nurses do when things go crazy? So I started working with Lecturio because I really valued their take on education. And this is why I started working with them, which is only matters to you in the fact that all of us are educators at heart, and it is our deepest desire to help students be prepared to be safe and to use sound clinical reasoning, just like Dr. Benner shared. So what I'm going to share with you is like having a virtual teaching assistant, like a student tutor that can support your practice. That's what I wish for all of my colleagues, because there are just not enough hours in the day. I teach pharmacology and I teach advanced pathophys, and I am still in the classroom. Even though I work with Lecturio, that was one thing that was very important to me, that I not lose sight of what it's like to be in the trenches. And you know what we have all just gone through here in the States is the end of the semester. So that's been a really interesting time to be a faculty. And there literally is not enough time in the day to talk to every student, to meet with each student, to tutor with them, to provide what you want to, because you're just one person. And then I found Lecturio, and I found that I could really offer things to my students that helped kind of multiply my efforts. So it's not meant to replace a faculty, because nothing can replace a faculty, and the conversations that you have with them and the learning that you go through with them and checking their learning, that has to be done by a human. But you know, clinical learning was challenging before COVID. I wonder if anyone else can relate to that. If you've been in nursing, I know you have, and especially trying to teach clinical skills. Lab space is often very limited. When you have a group of students, you know, I'm short. I'm only a 5'2". So if I'm in a group of people and I'm trying to see, I really have a hard time seeing sometimes. So if I'm trying to teach a student how to start an IV, it's difficult for them to all visualize at the same time. Now, we do our labs in groups of students because we have limited lab space. That was a beautiful center in the Rise Tower, and I like that name. Looks like there is top-notch stuff there, so I love what you did for your students. But we also know that students learn at variable rates. Some catch on really quickly. Some have very strong psychomotor skills, others do not. They're much slower. And then lastly, again, there's not enough nursing faculty pretty much wherever you are across the globe. We need more nursing faculty. So these are the challenges that face us before COVID, definitely during COVID, and then long after COVID, we'll have the same problem. Okay. Did you guys take the screen? That's fine. If you needed to do that, you let me know if we're having problems on that end. But let's talk about those challenges that we had with clinicals. Like with space being limited, something with an online platform, which that's what we're talking about today, is an alternative platform, something that you can do to help with clinical competency. So with lab space being limited, it's unlimited when you do it in an online format. When you talk about students have a hard time seeing, well, when we do a 3-camera shoot, that means we have overhead angles so that people can see. So some of those problems and challenges that we face: limited space, you have unlimited when you use an online alternate format. You have students able to see because we have cameras from the right and the left, so we can give you very close-up angles. And for students that learn at different rates, they can go over and repeat and watch and rewatch, change the speed of how they watch something. They can slow it way down if they need to see it. And then lastly, without enough faculty, you can augment your teaching with the video lessons. So we're looking to augment your teaching, not replace your teaching. And we use learning science-based tools like spaced retrieval or interleaving topics. And those are the things I want to talk to you about. In addition to our platform, I do want you to walk out of here with things that are useful, because if you're a faculty member and you've taken your time to come here, I want you to leave with some really helpful tools that will help you progress. Okay, so now we're back. Wow, fantastic. Well, I will, I'm not sure why we're having such a problem with that, but we've talked about the problems with challenges. Now, here's what we can offer you with Lecturio is that we have video lessons. And so this is the format that they asked us to come and talk about today. Now, the things with our videos is that they are short and concise, just like people's attention span right now. So we have a very succinct program. It's available to students to help them capture things in a short format. So I see now that we have the slides on the screen. So if you would help me, we'll work together with the IT people there. Oh, you're fantastic. All right, keep going. We have a few more slides. Yeah, if you'll just keep progressing. Yeah, this is the different presentation. Okay, so that's all right. That's the different, I sent the presentation just today. So we'll keep rolling. They're really gonna do it to me. Here's what we have. Short videos, just like your students' attention span, they run very quick, very brief, and they are usually about 7 minutes a piece. So that's the average. Now we have over 160 hours of video at 7 minutes a piece. So you can get very specific on what you want your students to learn. Now, in addition to that, we know that the science teaches us that the best way, the most effective way to learn is to quiz yourself. So we do that work for your students. Now, I know in Dr. Benner's presentation, she talked about if you give them a question, then that kind of guides them. And in a simulation, I agree. I can see why that is actually a good point. What we're doing with Lecturio is we're helping your students gain that initial knowledge. You know, you can't really connect the dots until you've collected the dots. So your students need a specific set of information before they can start to work with it. So that's what we're offering. And it's graduated and leveled from the first part of nursing school all the way through the end of nursing school. We've got 4,000 questions for your students to answer. And the intent of these questions is to help them progress through the levels, help them initially when they're just trying to recall information. We have those straightforward questions with every video. Then we have higher level questions like you would use for your end of course exams. Now it's accessible on a mobile app. You've got it everywhere. So it is accessible. If someone has a cell phone, they can use it. Now they have to have younger eyes than me, but you know, a lot of our students are very big on using cell phones. So next, let's talk about after COVID, like what happened during all that. It was a brilliant plan we saw laid out at the beginning of this conference, incredibly well organized. So I really appreciate getting to see that and getting to that being shared with us. What we can offer, and I'm going to start at the very beginning. So what I'm talking about are the fundamentals, the things that nursing students are just beginning and starting off. We have a clinical professor, and we have 2 courses for fundamentals, fundamentals of nursing theory, and also we have fundamentals of clinical nursing skills. Now I can make this PowerPoint available to you, so you're welcome to look at it. But right now it'll just be kind of us hanging out together and talking about it. The fundamentals faculty is Sam Ray. And I'll read you a couple of the comments of what the students have said about it. It says, nursing, fundamentals theory, nice, very good. Short and concise lectures helped me very much. That was from GA. And another student said, visually appealing. She did, which was on infection, and it was breaking the chain. So he said, this lecture was informative and very visually appealing. Samantha made the revision of the topic look easier. So that's really our goal, is to break it down. I know on your way to salience, there are small pieces you need to understand first, and that is our philosophy at Lecturio. We want to break things down. We use a lot of abbreviations and words that don't make sense to novice learners. Our goal is to help provide that knowledge, build the foundation, and then help them develop their own house on that structure. Now, the next slide, when we looked at it, I don't know that you can't see it, but I want to show you an example of how we teach students about documentation. What are the guidelines for good quality documentation? So that's something that is a real struggle for our students to understand. So we teach them the difference between incorrect and correct. So if it's a factual thing that they're charting, we would say the patient seems like he is having pain. But the correct way would say the patient is grimacing and moaning when his leg is touched. So we're trying to teach the student to document what you see and what you experience, not what you're judging or what you're evaluating on that. So for a factual one, that would be an example of what we teach them between an incorrect and a correct answer on that. And we go through factual documentation, accurate documentation, what's complete, what's current, and how to organize it. So with these beginning learners, getting the opportunity to learn how to document is part of our fundamentals course. Now, what I would love to show you is some pictures, and it doesn't really look like we're going to be able to do that. So let me just verbally walk you through, and I would be happy to show you a clip of the website when we get the opportunity to do that. But for the first skill I wanted to show you is an introduction and pre-procedure video for inserting an IV. So here's our philosophy. In this course, Nursing Fundamentals Clinical Skills, we have structured all the skills in the same way. It helps your student have a regular and consistent scaffold so they know what to expect as they're trying to learn this new skill. So I'm going to show you, I'll just ask you to visualize since we're having technical problems tonight, but we're looking for what your students would see if they're trying to develop online abilities, right? So we're looking at these skills, they see them online. Now you can use these before your students come to clinicals. You can also use them if your students are unable to attend clinicals. But initially, they're going to see the topic introduced. And then there's a little button down there. They just click materials and they can download our notes. Now there's a couple different strategies on that. Some students like to have notes with them and read those before they watch the video. Some students like to take notes on there, but I'll share with you our strategy on note taking. And we do teach your students the most effective strategies for taking notes so that it will encode more effectively in their brain so they can retrieve it when they need it. And I love, if you've read the literature on intuition, you know, what our nurses' intuition is what Dr. Benner was talking about. We have seen so many people with CHF. We've seen so many people in kidney failure. We've seen so many liver failure patients. It makes going to the mall really unusual, doesn't it? Because when you go out in public or go to the park, which we don't get to do as much with all the COVID lately, but when you go out and you see people, you can recognize challenges and diseases that they have because we have developed that nursing intuition, which, as Dr. Benner shared, novices do not have that, obviously, because they haven't had that experience yet. So we have this opportunity, depending on how you want to use it with your students or what they find the most effective, where they have every graphic and visual that we have in the presentation. So they just click that little materials button and they can download exactly what they're seeing on the screen. So we start with that. And then right next to that, we have some other options for them. They can click it into different, they can click on transcript, where they will see all the words that the speaker or the faculty is saying throughout the presentation. So they have the opportunity to do that. So if we get right into a skill, and what I wanted to share with you today was an IV start. So we talked one of our students into this. He was a former student. He's now a nurse. So his grade did not depend on him doing that or meeting with us. But we talked to one of our former students and he came very well hydrated. I mean, very well hydrated. And he allowed us to use him as an example so that we could start an IV on him. So his name is Peter, and we are forever grateful to him that he was well hydrated, and that got to go very well. So Sam did, Samantha Ray is the one who did this on him. And let me read you what the students have said in their review of this video. IV catheter insertion, very clear and thorough with good explanation. Appreciate the graphics of the IV angle insertion and venous lines. And this is what I would really encourage you to just reach out and contact me, and I will show you some pictures of what we have for this, because this is something unique, and that's why I was so excited to get to go work with Lecturio, because what we know with learning is that students need to see visuals. Like I wish I could show you right now. Students need to see visuals of what they're learning. With these clinical skills videos, we're teaching them, and they can watch it in the time that they want, watch it as many times as they want. Basic clinical skills, IV starts, Foley catheter insertion. We've got ostomy care. So we've got multiple skills that we have shot in a clinical setting with a practicing nurse, walking them through every setting. Now, how we start it is every video starts with just her talking. Sam's very personable. She shares, hey guys, this is what the skill is all about. Now, these are the steps, and they're numbered for you. So you can see numbered steps on how you do that. Then she'll go through and demonstrate the skill. And we've used a human as much as possible. So we have the ability for you to see that skill in real life. We even have some assessment videos where they've done a pelvic exam and a prostate exam on real people. So the Foley catheter videos we did were on a model, but the assessment videos we did with a pelvic exam and a prostate exam, which I know undergraduate nursing students are not going to do, but those were also done on real models. So we're putting out different skills. And this is the features that you will see of these videos. You'll see short little inserts. They'll give you rationales for the clinical skills throughout. So you'll see Sam demonstrating how to do this skill, no matter what it is. And you'll see little inserts that are right on the screen, right near the skill. Like, for example, with IV starts, you'll see an insert that says, avoid using the inner wrist as an IV insertion site. And she explains why, because of the risk of damage to the nerves or something along that line, so that you know why you would not do that. Now we're building a scaffolding throughout that. Just like you would give a lecture to your students, you would tell them, this is what we're going to talk about today. These are our objectives. This is what I want you to understand by the time we're done with today's learning experience. We do the same thing with the skills. This is a skill we're looking at. And then throughout the video, remember there are multiple short videos, we have inserts that will come right on the screen and remind the student of what you're doing. Now you heard that one review where the student said, I really appreciated the angle. Students are always afraid to stick a patient. You know how stressful that lab is. So we kind of get the ones that go in so slow that they make it worse, or they try and stick it perpendicular. So you'll see on the video that Sam is actually right at a 10 to 15 degree angle, and we've actually drawn that in on the insertion site right on the video for you. So it makes it easy for your patient to do that. Now we have that covered with 3 camera angles. So you've got it coming from overhead the patient, from the left and from the right. So there's no bad seat in the house. Everyone can see what we're doing. Now, oftentimes in lab, we speak quickly. And, the students, I call it bobbleheading. It's that illusion of mastery. Oh yeah, I got it, which usually means they were able to follow you. And we all know that following along with an expert who knows what they're doing and actually understanding and mastering that information are 2 very different things. So in the video, we use a lot of visuals. You'll see on the arm of the student or the former student that we've written down proximal and distal. So she explains why we want to start proximal and work distal down the arm. You'll also see on another one where she talks about the veins. You'll see the patient from overhead, you'll see their arm, and you'll see the tourniquet. And then we have put an overlay in of all the veins that are there that the student has to pick from for an IV insertion site. So instead of me being a faculty in the lab trying to say, hey guys, we have all these veins here in your arm, you've got this, or using a picture, they can actually see a nurse looking at an arm, assessing it, and seeing the veins all laid out with an overlay on the video. So it's really helpful to students to see that right on the site as an expert is talking them through, and it's easily visible. We've also, we'll sum up, we'll talk about, hey, now remember, this is what we just said, which is great teaching practice because you are summarizing for them. And then after they watch the videos, we ask them some recall recognition type level questions to help with that initial learning of the concept. So you'll see in these that we actually stick a live patient, like I said, which this is one of our students love this video because this is the one that everyone's nervous about when it comes to that. So you'll see her actually really go through that. So we obviously won't show the video clip today, but I want to talk to you about a study. And I know that our goal today was that we would think about and talk about what went on during COVID. So there's a study that came out just this year in 2021, and they looked at students and what their preference was for learning during COVID. So they gave them 3 options in part of the study, and I would be happy to forward the study to you. But they looked at electronic live lectures, pre-recorded videos, or self-study. Now, 40% said that they liked electronic live lectures, but nearly 60% said their most preferred was pre-recorded videos. So hardly anyone was totally up for the self-study all on their own, but almost 60% said they preferred pre-recorded videos. Now, those are generally ones that the faculty have done, right? That's a PowerPoint with our voiceover on it. You all know what we do, right? Those are the resources that we have. Students didn't have access to rich and robust resources like we can provide for your students. So how do these work? We know that students actually like them. Like, these are not run-of-the-mill PowerPoint presentations. These are full-on edited, vetted, watched by medical teams and nursing teams and for heirs. And these are highly vetted before we actually publish them and put them out. So what impact has that had on learning? Well, in student satisfaction, we have had a really high, almost 90% of our users have said they would recommend to a friend. Over 90% say that Lecturio improved their exam scores, and it said Lecturio helped them reduce their exam stress levels, which a stressed brain is not an efficient brain. So that's really a bonus. Now, we also watched that with just 12 hours of watching. Remember, we're over 200 now. They got 37% more correct answers in their performance. So they were able to actually take the videos, use the process in the system, and really be able to raise their test scores. So when we talk about reinforcing retention and recall, here's a pro tip, right? Since we are all colleagues and we're all faculty, I want you to think about, what do you do in the classroom to help your students learn? Many of us, as you're teaching, you'll pause and ask your students to recall something, right? Well, the video system, the learning system, does that for them. They will watch the video, and as they're watching the video, they can take notes right on the screen, or they can write them on the paper notes if they wanted to print them out. But at the end of every video, it's going to ask them to recall the most important points to them, what they found the most useful and the most helpful, and they can type it right in there. Now, the system, the learning platform, will save that for them right there. So they can go back and access their notes and use that when they're reviewing and when they're studying. The second thing I want to recommend for increased encoding, and that's really where my interest is how do we help these novice students really gain the knowledge that they need to make that safe clinical reasoning and judgment? The second thing I'm recommending is called interleaving. Now, the reason interleaving is important is because you have the opportunity to be asked questions and reminded of concepts that you didn't just watch. So in the system, what you have is the opportunity to have questions, recall recognition questions, rolling through on a consistent basis. So here's how it works. You watch the video, you answer a question, and then you rate yourself. I felt really confident in that. That's green. Kind of neutral on that. That's the middle. or read, no, I totally guessed on that. So the system knows we're teaching your students how to self-assess. If they feel very confident about an answer, they won't see it for a while. That'll be the longest time before they see it again. If they felt neutral on it, they'll see it a little quicker. And if they didn't feel good about it, they'll see it right away. So what we're teaching them is, if you're using the platform, they're going to interleave. They're going to see different topics at the same time. So they don't just get hammered. Like what Dr. Benner said, when you ask questions that are specific to a content, they kind of know what's coming. But when you use interleaving, you've assigned them multiple questions within the system, and those will just keep coming up over and over again to help them learn that information. So you've got that red, blue, and green system, and we use spaced repetition and metacognition. So metacognition is just thinking about your thinking. And we all know from the research that novices are the poorest self-assessors. They overestimate how much they know. They have the illusion of fluency. They think because they could follow you, like we talked about in that lab setting, that they've got it, but they don't. Or if they've looked at their notes just 1,000 times, they're like, okay, this all makes sense to me, but they can't extract the information and build on that and apply it. And that's really what we want to teach them with the Lecturio system. So think of it as a virtual teaching assistant for you. It's like a student tutor that is available 24 hours a day, and it supports you as a nursing faculty. Now, the Commission on Higher Education, I've heard you all call that CHED, the Lecturio content has already been mapped to that. So it's been mapped to your national curriculum, including the RLE content bundles with clinical skills videos. So it's tailored right to your curriculum. It's all set up and ready to go. So for you as a faculty, you've got comprehensive content for teaching in these short videos that are now well over 200 hours, and we're releasing more every week. You also have formative and summative assessments. You've got access to that. Over 1,200 QBank questions. You can use exams, and it integrates with whatever learning management system you have. And the cool part about that as a faculty is that the Lecturio team will take your syllabus and plot that all out for you. So you can just have a link in your learning management system, and you don't have to do all that work. Now, we also can show you detailed statistics on your students' progress, how much they're engaged, how many questions they've answered, what their score is, some pretty cool stuff that we could teach you. Show you if you wanted to have a further demonstration. But what I wanted to say is that the faculty at Nursing Lecturio, we're all practicing faculty, and our job is to work for you to support your faculty. So we want you to be able to teach in your classroom the way you find the most effective. We just provide some extra support for that students when they're initially learning a concept, when they are sharpening their skills. For a student that needs tutoring or remediation, we can set up to help you to do that. We work with any learning management system. It gives you a single sign-on, which means we can show your students that it's a seamless back and forth between your learning management system and with LMS. And we can provide you with all kinds of data to really drill down and find out what's going on with your student. All right. Well, I thank you for your time. That is my presentation minus any PowerPoint slides. But if you have questions for me, I'm going to put my contact information in the chat. And if you would like me to send you the PowerPoint presentation, I would be happy to do that, or to show you anything on the website. Thank you for the invitation to come today.
Thank you very much, Dr. Rhonda Laws, Director of Nursing Program from Lecturio. And Lecturio would like to invite you for their upcoming workshop on curriculum enhancement. And the good thing is the registration would be free. So please take a screenshot of the link. And this is happening on Friday, June 11, 2021, 3:00 p.m. Philippine time. And this day will not be complete without hearing the message of the CEO of Lecturio. So let us watch this video presentation.
Good morning, everyone. This is Stefan Wisbauer from Lecturio. sending my best wishes for your event this morning from Germany to everybody at the Our Lady of Fatima University team. With special greetings to Dr. Enriquez, Mr. Santos, and the Uwayan. And I've been looking at your core values, and I find we're in many ways very compatible around your hardworking, inspiring, and ethical approach. And I notice you have visionary in there as well. So it's a special honor for us to be working with you. As you know, our vision includes making medical education more accessible, bringing more learning science into it, and building the best potential digital tools to achieve that goal. But never, medical education will never be purely digital. So it'll always be delivered in a blended format with partners like yourselves. And I couldn't think of a better partner to be working on now across medicine and nursing. So I wish you all the best for your nursing conference this morning. And we stand in support and look forward to not just getting your feedback, but also getting your ideas to make sure we jointly continue on this visionary track for the future. Best regards from Germany, and all the best for your event.
Right, that was the CEO of Lecturio, Stefan Wiesbauer. At this point, allow me to acknowledge the presence of our Vice President for Student Affairs, who happens to be a nurse as well. Okay, let's all say good morning to Dr. Maylene Santos. Dr. Santos, good morning po.
Hi, good morning everyone. And congratulations for this successful webinar. Congratulations to all of you. And thank you to all our speakers.
Thank you so much, Dr. May. At this juncture, we will have now our panel discussion, and we are privileged to have 3 educators to share their best practices on online instruction around the globe. So let me introduce our first panel. She is an experienced registered nurse, a nurse educator, and nurse researcher with a demonstrated history of working in the healthcare sector and higher education industry. She is skilled in healthcare research, teaching, and higher education. She used to work as a critical care nurse in one of the leading hospitals in the world. She utilized her clinical experience to be a more efficient and more effective nurse educator to aspiring nursing students. Her passion for lifelong learning has prompted her to be a researcher conducting both qualitative and quantitative researches. She holds a master's degree in nursing, major in clinical instruction, a postgraduate diploma in health science from Eastern Institute of Technology, and certificate in contemporary New Zealand nursing practice from Eastern Institute of Technology. At present, she is a nurse educator at Southern Institute of Technology, an alumna of Our Lady of Fatima University, BSN class of 2005, former Assistant Director for Research, and Chair of the OLFU Institutional Ethics Review Committee. Let us all welcome from New Zealand, Professor Jenica Ana Rivero.
So the first reported case of COVID-19 in New Zealand happened on the 28th of February last year. And then, of course, 2 weeks after, the New Zealand government mandated that everybody who's going to enter New Zealand must self-isolate for at least 14 days. Borders were closed, and 3 weeks after the first reported case, the government introduced a 4-tiered level system, wherein level 1 is basically preparation in case there are going to be community transmission, and level 4 is technically synonymous to lockdown. And on March 25 of last year, what happened was that New Zealand goes into level 4, and that is the actual lockdown or self-isolation. So the New Zealand government implemented its strategy of going hard and going early. So what does this mean? So it means that all essential services are closed. And even though hospitals, aged care facilities, primary placements are considered essential services, these institutions close their doors to clinical nursing rotations. So in a pre-COVID-19 world, originally we rely on clinical placements in training clinical competency of our nursing students. So what we do is that nursing school will typically affiliate with nursing agencies, and there are nurse educators who are going to oversight and supervise students in training. So this specific setup has been going on for several decades already. And even though healthcare is a field that is constantly evolving and constantly changing, the setup on how we train our nursing students remain untouched. So pretty much the setting is the same. Then COVID-19 happened. So in a world with COVID-19, what did we have to do? We had to pull out students from placement. And apart from that, we have, as educators, we had to adopt and adapt a range of new and familiar technologies and strategies. So we had to pilot test new teaching strategies. We had to rethink our way or our approaches to assessments and evaluation. We even had to build and identify on how to be a member of a community, albeit a virtual community. And also we even had to adopt new strategies on how we can recruit students. So if you are going to think about it, there were so many things going on and so many things that we had to accomplish in a matter of weeks. This is on top of everything and all the other worries that we had, because during that time, we are not really specifically aware yet of the information about the disease. So there are so many questions. What will happen now? What is going to happen, particularly to our nurses in training? So truly, COVID-19 has impacted nursing education. But the question was really, was that impact a form of an unprecedented disruption, or has it been a catalyst of transformation? Okay, so what I am going to share with you today are the strategies employed by a certain school of nursing here in New Zealand during the pandemic. So since we had to transition to online format, we need to think of ways on how we can do it in such a way that we are sure that our students are still obtaining the competencies that they require. So what you are seeing on your screen now are some of the strategies that we have employed. We have mass education, TLAN, or thinking like a nurse. This was mentioned by Dr. Benner a while ago, Dr. Tanner's model of clinical reasoning judgment. We, of course, had virtual classes through a platform known as Collaborate. Reflection was very much used during those time, and we suggested our students to use the Gibbs reflective cycle as a guide. We also had intentional practice of communication, which was very important as well. Debriefing and simulation using mixed reality, particularly HoloLens. So there are so many strategies, but for the interest of time, I will be focusing on these three: masked ed, simulation, and debriefing. So the first one is mass education. So mass education, or KRS simulation, is a teaching technique which is informed by a teaching process. So it includes the use of realistic body silicone props, which involves a mask, torso, legs, and arms, which are worn over an educator to mask them. Okay, so what happens is that this educator will have a rich character and a rich history, which will now become the platform for teaching. Okay, so the good thing about mask ed is that it is an interplay involving an educator, the character who is also an educator but is masked, and then of course the learner. So there is an interplay among the three, and the good thing about this is that it follows the philosophy wherein we are going to ignite all five senses of our students, which makes learning more powerful. They can see, touch, feel, say, okay, or talk to our math educators when communicating. And in that case, they will be able to experience the principles of obtaining knowledge, being able to participate in a realistic setting, and then of course, spontaneity is also involved. Now, so normally what will happen is that before lockdown, the math educator will be visiting our students in the clinical simulation suite or laboratory, and then the students will be performing physical assessment. However, since it is not possible, we have decided to conduct this session virtually via Collaborate. So the interplay was still present. So during that time, we utilized Wallace. He is a Korean vet. He was a Korean, he was an army during the Korean War, and he worked as a health medic. So I will show you a very short clip of how it went.
The best way to do it, and especially when you're learning, just do it as you go. Take your time. The patients don't mind. Sometimes the nurses are rushing by them at 110 miles an hour. So sometimes it's really nice for them to have a young student nurse who can actually spend a bit of time.
So you can see that the three-way interplay is still involved. Now, what's interesting to note during this session was that during the time that New Zealand was in lockdown, in case patient need to consult their GPs or their doctors, this is really done virtually. Okay, we had to call for appointments, we had to ask for a doctor, and patients during those times are going to be assessed, and they're going to have their consultation virtually. So this Collaborate session with our mask educators has truly been simulating the real occurrences that are happening here in New Zealand. So it reflects actually what's happening during those times. So even before mass ed was used during COVID, it has shown already to produce increased confidence among our students. Not only that, these are other advantages of using mass ed KRS simulation. So during the time that we were doing virtual, we noticed that even though the session is not done face-to-face, the typical competencies or improvements that we notice on our students also emerge. Okay, so during the Collaborate session, students are able to interact with the character in a humanistic way. And this specific technique gives rise to person-centered care. Their clinical communication skills were improving. And then, of course, it might potentially give rise to engaged problem-solving activities and purposeful reflection. Also, these sessions, we allowed our students to lead it in a way. They were guided, but these are student-led discussions, which are very crucial because this will result to active engagement. And active engagement is something that is academically challenging. And in that way, they will be able to enhance really, okay, their clinical reasoning skills. And apart from that, with academic exchanges among students, what happens is that you get to learn from your peers, giving rise to cooperative learning, which is proven to enhance engagement and increase a sense of community and cohesion. Actually, what's interesting to note as well was that there were some students who were normally quiet on face-to-face session of mass ed, but were very much engaged and participative during the virtual session. So that is something that is really worth investigating and something that we are going to look at. So this mass ed session via Collaborate, it also allowed for students to discover important situational cues which are present in the mass ed scenario, giving added value to the knowledge base that they already have. And then, of course, it aided in improving their clinical reasoning skills. Another strategy is also a form of simulation, but this one utilizes augmented reality or mixed reality, particularly the HoloLens. So the HoloLens has been shown to be beneficial as well. So these are known benefits of augmented reality or mixed reality. It could enhance student motivation and engagement with learning. So this is a new study by Frost et al. Conducted just last year. It has also been known to be a promising tool for instructing practical skills and has the potential to enable superior learning outcomes and potential to assist in enhancing clinical judgment and developing skills in noticing physical cues in patients. So I also have here a short video clip of how the technology was used during the time that we were in lockdown and how we are using it now that we are back to face-to-face session. So that is one of the ways on how we train our nursing students who are going to become healthcare workers in the future to be able to identify and manage COVID-19 even before they have access to real patients. We understand that COVID is a fast-moving situation and it is not going anytime soon, if it is going away at all. So we understand that it is important that we equip our students with the knowledge and the skills on how to recognize it, at the same time to be able to have access to information with regards to the latest knowledge about the disease. Another good thing that we did during lockdown was debriefing. So for every simulation, mass ed, and HoloLens session, we make sure that we conduct debriefing. Simulation is an integral part of the curriculum of this School of Nursing in New Zealand. And when we transitioned to the online format, we had to make sure that we're still able to assess whether or not our students were really obtaining the competencies that they need to obtain. And one of the ways that we did that was through debriefing. So with debriefing, we normally follow the International Nursing Association for clinical simulation and best standards or learning standards for best practice for clinical simulation. That's the guide that we're following. So it is normally composed of 3 stages: the pre-brief or the pre-work before the actual session. The second is the actual facilitation of the session. And thirdly is the debrief. It is very important because studies have shown that it is during the debrief session where most learning takes place in a simulation setup. Okay, so it's where it is touted as the place where learning takes place really. And apart from that, another thing that we have to consider every time we do the briefing is that it has to be facilitated by an expert in the topic and someone who is an expert at debriefing. Because if this is going to be possible, what will happen is that the students themselves will be able to identify their own learning gaps, which is very important. It's important for our students to know what they do not know. And then, of course, the facilitation will also fortify the knowledge that they already have, enabling them to have a deeper understanding of the lesson. And then, of course, they will realize the relevance of everything that they have learning. They will realize the importance of it because they're able to find out the actual or the practical application of all the knowledges that they have obtained. So we also perform debriefing during lockdown, and which is a good thing. And we are happy to find out that there are studies which will show us that the knowledge and the advantages that students obtain from a virtual debriefing session is at par with the benefits that they get if the briefing is done face-to-face. So there's no significant difference in the level of obtained knowledge and gained self-efficacy when we are going to compare the briefing that is done traditionally and the briefing that is done virtually. So I have shared with you 3 specific strategies that we were using during lockdown and right after lockdown in a way to enhance the clinical competencies of our students. So if we are going to look at it, these are testaments that in time of disruption in our teaching and learning, we don't always have to reinvent the wheel. We don't need to always look for new ways, new techniques, new strategies, or even purchase new equipments. What we can do is we can look at what we already have and then brainstorm on how we can potentially transform them in such a way that they are going to tailor fit our present needs. So clinical competencies can be obtained with teaching and learning sessions occurring beyond the 4 corners of the clinical environment. So let's go back to our question a while ago. Did COVID-19 disrupt or transform nursing education? Has it been disruptive or transformative? So for some academicians and educators like myself, I consider it as a form of transformative disruption. Okay, so COVID-19, for the lack of better word, it has forced us to transform nursing education, a transformation that has been brewing for the past several decades. So let's face it, whether we like it or not, COVID-19 pandemic has transformed our educational landscape, and it will never be the same again. So what are we going to do now? How are we going to future-proof our curriculum? We have seen how important it is to future-proof our curriculum because we don't know what we're going to encounter, okay, in the near future. So what we can do is we need to have a strategic and intentional planning, which are, of course, being led by leaders with visions. So it is important for educators, faculty, administrators, and even accreditors to embrace limitless possibilities and ensure that we are going to provide our nursing students with a teaching and learning environment which will put nursing science and art at the core of the curriculum, whether it be face-to-face session or virtual sessions. So what about our students? I'm sure you are asking and worried as to whether or not what your credentials will be once you graduate, given the fact that you have not had enough experience in the clinical placement to master these clinical skills. So what I want you to do is to look at these nurses. These nurses are students, were students like yourselves, okay? But at this point, they are helping us to battle or to fight against the pandemic. So take inspiration from them. Do not think that you are placed at a disadvantage, because unlike them, you have with you formative lessons that are very influential and very crucial in your nursing education. And these are the experiences, and these lessons are the experiences that you are experiencing right now. And because of that experiences that you are having before, particularly during, and hopefully after COVID-19, I can easily say that there is no better time in history than today to learn what it really means to be a nurse. Thank you, and may you all have a good morning.
Thank you for that wonderful presentation from New Zealand, Professor Jenica Ana Rivero. Ma'am Aika, I hope you can stay with us later for the open forum. And
Yes.
we should now move on with our second panel for this morning. Our second panel holds a PhD in Educational Management and has worked as Vice Director for Quality Assurance Unit and Director for Measurement and Evaluation Unit and Information Technology Unit Head. He is at present connected to University of Hail in Saudi Arabia as a clinical supervisor, clinical instructor, nurse specialist, and staff nurse. He has handled fundamentals of nursing, basic adult care nursing, practice clinical care nursing, practice and nursing leadership and management. Our second panel has also published several researches focusing on nursing leadership and management, clinical simulation, curriculum development, health education, evidence-based practice, patient safety, and clinical programs. From the Kingdom of Saudi Arabia, let us all meet our second panel, Dr. Ferdinand Gonzalez. Good morning, sir.
Good morning, Sir Ben Camino. Thank you so much, everyone. Thank you for inviting me to your prestigious international conference. So, to add up, I will just, can you all see the PowerPoint presentation?
Yes, doctor, we can see your
Yes,
presentation.
thank you so much, Sir Buen Camino. Okay, so to start with, okay, I am a consultant specialist here in Saudi Arabia in University of Hail. I've been teaching here for the last decade. So I will just be sharing with you my personal experience on how we adjusted our the delivery of instruction during COVID-19. As mentioned by the previous speaker, Dr. Rivero, Professor Rivero, she mentioned about the transformation that was made possible because of COVID-19. I totally agree with her that COVID-19 has transformed the nursing education in a way that we will develop new learning teaching strategies and new assessment methods to measure the performance of our students, okay? So without further ado, I'm going to start with my presentation now, okay? So all of you know and quite aware about the objective structured clinical examination, okay? So if this has been implemented in the Philippines already, so I am very happy that I will have my own platform to share with you on how we try to modify the objective structured clinical examination in the undergraduate program, okay? So before anything else, so just like any change that will be implemented, we had to make sure that the grading system will be improved, or what do I say, should be revised, so that it will not be biased to the students, so that they would be that their performance should be measured, you know, correctly. Okay, so now first we have to go back into our course specification or the field specification. We need to make sure that our course learning objectives are aligned with our teaching strategies, okay? So we asked, or we had some consultations together with other teachers and professors, that we need to make sure that the learning or the teaching strategies should be aligned with the course learning outcome, and that should be measured by the assessment methods that we are using, okay? So apart from what my previous speaker or the panelists told about different way of learning strategies or learning strategies, we devise interactive learning using audiovisual materials, discussion and questioning, problem-based learning, but we focus more into self-directed learning because we are now in the online system, okay? So this will fall into the responsibility of the students on how are they going to be disciplined to make sure that they will religiously attend all the online sessions that they need to attend, okay? So first, this is the grading system that we presented in our course. Next is we had to, of course, because of the COVID-19, the ongoing pandemic, we need to make sure that appropriate COVID-19 safety protocols should be implemented. Okay, so first there would be group arrangement. We had to make sure we had to make sure that there would be 2 groups that should be implemented: face-to-face and Blackboard session. So face-to-face, it means that the student will still need to report in the university, okay, to fulfill the 6 contact hours, while the other half of the group will have their own Blackboard session. So this is our list of activities, and this is our weekly laboratory plan. When we started our the implementation of our course using the online platform. So as you can see, the plan, it is divided into 2 groups: the Blackboard session and the face-to-face session. Okay, so just like what Dr. Loss discussed a while ago about Lectorio, so here we are using Blackboard as our learning management system. So the Blackboard, in the next slide, it will tell you, or it will help the instructors on how the instructor will organize all the course materials. Okay, here you can see that the instructor will be given a chance to make sure that all the requirements, all the announcement will be organized in this learning management system. You can also give learning materials such as video presentations, and you can also give all your handouts in this Blackboard learning management system. We can also use this platform to deliver examinations to the students, okay? Next, so these are the infographics that we made to make sure that the student will be aware of what should be done or should be adhered to prevent the spread of COVID-19. So, I don't know in the Philippines on how they are trying to make sure that the students will be, will try to avoid the spread of COVID-19 with all the protocols from the IITF and all the protocols from the government being directed to all the universities in the Philippines. Here in Saudi Arabia, we have an application platform. They call it Tawakkalna. This kind of platform application, it will see, or it will reveal if the students have the the signs and symptoms of COVID, and at the same time, it will reveal the information of the students if she or he has received the vaccine already. Okay, so as you can see, the yellow means cautious status. Cautious status, it means that because Tawakkalna is using location of that particular person holding in his or her mobile phone, it will detect any special gathering. And if someone is exposed in that particular gathering, it will immediately show cautious status. Now, the next one is allowed to enter. It means that that person or that student is free from any signs and symptoms of COVID-19. And the last one is not allowed to enter. So, technically speaking, that student or might be exposed or has ongoing or positive symptoms of COVID-19 or ongoing symptoms of COVID-19. So this is how we implemented our OSCE. So first, by theory, OSCE is made up of 6 stations, okay? 4 stations are based around scenario. The first one would be the assessment, planning, implementation, and evaluation. The next 2 stations are used for test practical clinical skills. Here in our university, what we did, we tried to modify it and made only 4 stations, okay? That will start with assessment also, the planning, implementation, and evaluation. But the 2 stations, we had to merge it and put it in the implementation stage, okay? Later, I'm going to discuss about it, about how we made sure that all the skills will be covered in the implementation phase or the stage of implementation. Okay, using this OSCE flowchart, I'm going to start with station 1. In station 1, the student will take down of notes. No? There will be documentation obtaining information. Okay, so the student will be given 3 hours. In this particular station, all groups will be group of 5 students only. This group of 5 students, they will be guided together with their teachers. Okay, it is the same thing like we are doing in the Philippines. You know, before we had to plan for rotation plans, clinical placement. Then again, we had to adjust because, of course, they are not allowed to go to the hospital. So what we did is to group it in. We grouped them into 2 and 5 groups, 5 members in one group. And it goes along also that these students will be guided with their teachers as well. Okay, in the station 1, the teachers will be with them while they are taking down notes. As you can see in the picture, our students, together with the clinical instructors, okay, they will be given a case scenario. This case scenario, it's like the cardex that we are using in the Philippines. You know, it's the synopsis, it's the summary of all the information that is present from the patient's chart. Okay, so what we did, we went to the hospital, and these are actual guided with the confidentiality and anonymity. Okay, so we had to make sure that the contents of the case scenario is realistic. Okay, so that the documentation of the student will be also realistic. Okay. Then, from this scenario, the student will jot down notes in this clinical log. They are going to transfer all the information, pertinent or significant data from the case scenario. Okay. Then, there would be role play if it needs to have simulation. For example, the scenario is talking about an aware or conscious patient. Then we have to make sure that the clinical instructor will take the part of the patient, okay, and the student will now interview the instructor. This is how we do it when the situation requires it. Okay, so they will finish the clinical log, okay, in 3 hours, and then after that, the student will proceed to station 2. In station 2, they will be given 1 hour for that. It has a separate room. It has a separate room also. The focus is more on diagnosis and planning. Okay, the student will list down actual nursing diagnosis and potential nursing diagnosis. Okay, so they will use the nursing care plan form from the clinical log, from the previous form that I have showed to you. In this station 2, it is also called silent station. The teachers will be with them, guiding them on how are they going to formulate the nursing diagnosis. So, as you can see, this form, they will accomplish the assessment part, potential diagnosis, planning, and implementation, up to the implementation phase only, okay? Then now, these illustrations or the pictures are showing you our clinical instructor or teachers assisting the students on how they are going to formulate their nursing diagnosis. So, as you can see, we prepared it beforehand so that the student will directly perform the procedure as the scenario requires it. Okay, so in station 3, there will be OSCE cards that will be given to them. This OSCE card is related to the scenario, of course. These are actual doctor's order that the students need to do or needs to perform. For example, the patient FA, CVA, diabetes mellitus type 2 requires random blood sugar monitoring. So as a student, he or she is required to demonstrate the level of competence essential for safe practice. She needs or he needs to fulfill or fully consider the scenario and should maintain a communication with the doctor. In communication with the doctor, the student should use what? The scenario, the clear rationale about the purpose of the procedure. Okay. So the next one I will show you. This is the station 3, the actual student demonstration. Now, the clinic instructor will hand over the OSCE card to the student, and the student will read aloud the contents of the scenario. Has CPA, diabetes mellitus type 2, requires around blood sugar control. Okay? As student makes you are required to demonstrate a level of competence essentially for safe practice. Fully consider the scenario, contact with Dear Ahmed, the third experienced teaching staff, by telephone and quickly and straightaway communicated with the care or him. Okay, so as you can see, the student was able to read aloud the contents of the OSCE card. Okay, so that his classmate will also be aware of the scenario itself. So we use a group learning technique in which the students will help each other. Okay, and then after that they are going to follow the step-by-step requirements of the scenario. They are going to prepare the equipment that needs to be prepared for that particular procedure. And then after that, as you can see in the picture, after they perform the required scenario or the required procedure, the teachers or the clinical instructor will give direct feedback right after the procedure. This is to make sure that the student will be reminded about their performance, the things that they should improve. Okay, so this is how we make it possible that the teachers will also be involved in reminding the students to make sure that they will do better the next time they will be performing the same procedure. Okay, so this is the actual checklist that we use. Okay, so we adopted a four Likert scale from Journal of Nursing Education. This is to make sure that each step of the checklist from Taylor's checklist of manual of nursing procedures will be evaluated. Okay. Then the next one, after the performance of the nursing procedure, they will now proceed with the station 4. Okay, in station 4, this is a silent station. This is also a part in which they are going to document. What are they going to document in this station 4 or the evaluation phase? They are now going to finish the clinical log that they started before in stage 1. They are now going to complete the nurse's notes following S-bar, and they are now going to complete the evaluation of the nursing care plan. Okay, either it's goal met, goal not met, or goal partially met. Okay, so also as teachers, we had to make sure that all assessment methods that was given to the students were properly item analyzed. Okay, because at the end, we as teachers, we need to make sure that we are calculating the achievement of the course learning outcome. And at the end, we were able to get a good evaluation from the students and the faculty as well, because the students were able to achieve their target grades, and they appreciated the fact that even without clinical placement, we tried to mimic the environment in the hospital, make sure that we achieve the course learning outcome without direct patient care. This is our role as educator. We need to work extra mile. Okay, we need to put more effort so that the students will have or will be provided with experiential learning even without clinical placement. Because at the moment, it is not only in the Philippines who is experiencing in the rest of the other countries, but also here in Saudi Arabia. So, guided by the Minister of Education of the Kingdom of Saudi Arabia, we were mandated to make sure that the students will be safe. Okay, that is our first priority. So, this will not happen without the collaboration between the male and female campuses, because here it's separated. We have their own system in the female college, and we have our own what we call this own system in the male college because of cultural and religious beliefs. So we need to make sure that we have to overcome that. So before we implemented fully the OSCE, we had to do several consultations from the female sections, and of course with the approval of our department heads and our dean, to make sure that this new learning strategy, or as the same time as assessment method, will be fully implemented to the students. So thank you very much for your undivided attention. That would be all.
Thank you very much, Dr. Ferdinand Gonzalez from the University of Hail from the Kingdom of Saudi Arabia. We now move on to our final panel for this morning. He holds an MS in Nursing and an alumnus of the Our Lady of Fatima University. At present, he is an assistant professor of nursing at Gateway Community College, adjunct clinical faculty at Southern Connecticut State University and Yale University School of Nursing. He is a certified adult critical care nurse and cardiovascular nurse, a member of the Sigma Theta Tau International. Our panel was also conferred several awards for his dedication and hard work, including the Nurse Hero Award given by AACN South Central Connecticut Chapter, and an Outstanding Alumni Award conferred by the Our Lady of Fatima University in 2019. Our last panelist for this morning, let us all welcome from the United States of America, Professor Bienvenido Tabuso Jr. Good morning, sir.
Good morning, everyone. Hello. I know I'm the last panelist, and the talks have been so great. The speakers are great. I live in the United States, and the East Coast. It's almost midnight here. It's most of us. It's past our bedtime. But I will try to share with you what I've learned about online clinical. Okay, I'll share my screen. Okay, as I said, thank you, Professor Arnell, for that wonderful introduction. I work as a faculty at Gateway Community College and adjunct faculty at Yale University School of Nursing. I still work as an ICU nurse at Yale New Haven Hospital, so I wear so many hats. I have a few objectives that I want to share with you today. One of those is to discuss our challenges to online clinical, and I want to identify online platforms that we think enhance students' learning, critical thinking, and clinical skills, and share with you the lessons we learned from the online clinical experience and the areas for improvement. Just like you, faculty and students, when a pandemic came and we are switched from on-ground, we call it on-ground for face-to-face clinical, to online clinical, there were thousands of questions, and what are we going to do? I want to borrow what Dr. Law said, the struggle is real. It was real because we don't have, as Dr. Uwayan said, there was no manual, there was no structure on how to do online clinical. And so we researched some kind of data or to guidelines. So what we found was written by Dr. Bauer as a, she wrote this for the Sigma Theta Tau paper, that what's the goal of nursing education is whatever platform we going to use is to prepare nurses of tomorrow with the broad set skills that include sound knowledge. That means to say our curriculum should be robust with didactic and information, and also advanced thinking, ability to make accurate judgment, as Dr. Benner and Dr. Kyriakidis says. Sometimes we have to allow students to make mistakes in a safe environment for them to learn the clinical skills. And number 4 is technical proficiency. And we just, right now, the world is getting smaller because of technology. We could have not done this in midst of COVID without the internet. So students have to learn how to use technology for their advantage, and as well as the faculty, we have to use that for our advantage. we want to teach our students to be flexible, to be adaptive to whatever scenario or whatever cases that come their way. So we have to teach them how to be flexible, professionalism, and impeccable ethics. This is something that we have to inculcate in our students, that whatever we do, we have to be professional in our dealings with our patients, with our coworkers, with our fellow students, with our fellow clinical instructors. And of course, we have to maintain the highest moral and ethical standards in everything that we do. So what were challenges to our clinical online? And I'm glad that Dr. Petrovic and her cohort in 2020 made a study, and it kind of goes along with what we struggle with or challenges. The online clinical, there is the absence of physical cues when interacting online, the loss of tone to accompany the written text. And it's true, we just send instruction to our students and say, here is what you're going to do in written, but there's no, it's very impersonal. There's no someone telling them, there's no someone say an emphasis on what they should do on a certain direction. So the students, they feel so isolated in an online environment because there's an increased need for student self-direction. So we see that as in the clinical online. And the heavy reliance to technology, and technology fails, and there's no 100% technology that, computer fails, internet is a struggle sometimes. And a lot of our faculty and students had expressed that doing clinical, I know this is something that you probably the clinical faculty don't want to hear, but a lot of the faculty and students had expressed that doing clinical online is a lot of work. It's better to just go on ground, face-to-face clinical than do an online clinical. However, in the midst of this, we are all doing the best we can, and we did. When we did the clinical online, we have preconditions. I know there's so many, but I just mentioned a few for the interest of time. When we say we're going to do an online clinical, the students and clinical faculty must come to clinical, on the online clinical with a mindset that they're going to take care of real patients. Even though it's a virtual patient, they have to take care of that patient like a real patient in a face-to-face, and they are in a face-to-face or on ground. So we required our students to wear uniform, and attendance is required. As I'm sure you're doing that too. And it's a block schedule. It is for us, it's a Monday and a Tuesday clinical. From some students are from 7 to 3, and other students are from 3 to 11. So we have to make that block schedule so that everybody knows when the clinical is going to happen. And also, I'm one of the course leader, and I have to monitor the students and clinical faculty's activities because it's one of the requirements by ASIN standards. ASIN is our accrediting body here in the United States. And also, it is part of the State Board of Nursing that we should monitor the number of hours the students are spending on clinical, because there was a 50-50 rule that they imposed on us, 50% on ground or face-to-face and 50% online. And as we almost self-regulated this, and so we had to monitor that, and that was the condition. The other condition that we, when we implemented clinical online, is the instruction should be clear as to what are the expectations. And the grading rubric should be well explained to students. The students are, as I already said, that they are already isolated in a way because they are almost self-teaching. They are teaching themselves. But if our instruction is not clear and the expectation is not well stated, then the student will be lost even more in an online clinical. So, and also there is a constant assessment of student and clinical faculty's internet capabilities. And because of this, we have to constantly monitor them. What's going on in your clinical? What's going on with your internet? Are the students learning? So we constantly monitor them. And because of this clinical, and I said the faculty and students have already expressed it's too much work to do an online clinical, there is support that we have to give them, some kind of support to students and clinical faculty. It is not just the students struggling, it's both. Even the clinical faculty are also struggling with this clinical online, and that's just the reality. And also, the third condition that we put in ourselves is that clinical faculty should be strategic with the pre and post conferences. So what does it mean is, so we'll give a scenario, whatever platform we're using, and there should be some kind of pre-conference. That means to say the clinical faculty has to meet the students and lay out how to better learn the material. And that has to be done by the clinical faculty. And at the end of, say, for example, 4 to 6 hours where the students are doing their scenario online, at the end of that, the clinical faculty has to meet the students kind of in a post-conference, kind of tie up the loose ends in a way, so that there is the clinical faculty can evaluate what the student learned from the platform that they use. These are some of the platforms that we use right away after COVID-19 and unfolding case studies, and I'll explain a little bit more about them. My Neighborhood by Pearson, ATI Resources, and what the thing that we like the most is Swift River from Nurse Think. The unfolding case studies is something that we use right away at the beginning of the COVID, because that's what we have. So it's just basically a case study with a lot of questions after. And by the way, the National League for Nurses and the QSEN, or Quality Safety Education for Nurses, they have great resources for unfolding case studies. So if there are any clinical instructors, if you want to use unfolding case studies, they have great resource and they are free. You can go there and if you want, I can post this to the website. They have great resource for unfolding case studies. However, unfolding case studies have limitations. It can trigger critical thinking, but it's not the clinical skills will not be. It's not a lot that you can do with unfolding case studies. What do we have is what we call the My Neighborhood, My Neighborhood 2.0. And by the way, they are updating this now to 3.0, so it's more interactive. However, this came with our books. The textbook that we are using is using this Neighborhood 2.0. On the left side hand corner is this. By the way, this neighborhood is good for community health nursing. So we use this as a community health to educate our patients in the community, or clients in the community. In those patients or those faces that you see, virtual patients or virtual clients. So if you click them, you will see the scenario that they're in. One particular group of patients or clients is the Ocampos. They are Danilo and Lydia. I like them because they are Filipino descent, and they are immigrants, and they live in the neighborhood, and they speak Tagalog. So there's kind of language barrier, the kind of thing. In Lydia, not her real name, of course, it has dementia. So talking about being immigrant with language barrier and has dementia, so that's a lot of stress for both for this too, for the family. So you can there's so many. If I can show you, I think I'm not sure if I'm sure, but there's a season and episodes. So there would be some seasons like a winter season or fall season, and they have episodes so there's so many things that you can do with this. There's so many episodes that you can follow this family. In the interest of time, I want to play the video, but I just, because they can talk, these two can talk, but I don't think I have much time for that. But anyway, the other platform that we use or we're using is ATI resources. We use this for our high stake exams. But they have in their arsenal, in their resources, they have what we call video case studies. that we also used very early in the COVID, when COVID came in. And what I like about this is I cannot play the video because it's from ATI website, but a nurse kind of giving a report to one another. So as we students who are listening, how the report is going, and we kind of know what the patients by their report. So it is a very interactive, would I say, tool for students. And the last one that we are using now, we are using this heavily. I know this. By the way, I'm not connected with this company. We are just using that because our school purchased it. It's Swift River from Virtual Clinicals. What I like about this is you can create your scenario. They have about more than 450 patients or clients in this scenario, and they're adding more as we speak. And because my background is in critical care, I like the scenario about the emergency department. And what it does is it gives you a different scenario. One of the simple activities that here is triage. So a student will be exposed to different scenarios. And one is this, they will be given different patients. And as a charge nurse, I will be assigning different patients to different nurses with different levels of skills level. So I'll have to choose which patient is best for, say, nurse A with a limited experience. So that's kind of gives you a scenario of, some may choose, they may make mistakes, but that's the beauty of it. It's you are in a safe environment. The students are allowed to make mistakes, and yet they learn from it. So I like the scenario because of the critical thinking and the triaging. Now, whatever platform we use, we provide our students with tools, and those tools are there's so many, but I'll just mention two of them. One of those is SBAR, and Dr. Priya Hidis has mentioned about SBAR. SBAR is a structured communication model providing patient information. The S stands for situation, B stands for background, A, assessment, and recommendation. You're probably using this already, but it's an organized way of communicating with one another as a healthcare provider. And then on your left-hand side corner of your screen is the structure of the SBAR, how to build your SBAR. And on the right side is an example in SBAR. For example, this is a report to a physician about a critical situation. The situation is, hey, Dr. Jones, this is Sharon Smith calling from the CCU. I have Mr. Holloway in room 217, a 55-year-old man who looks pale and sweaty, feels confused and weak and is complaining of chest pain. And you will say the background is the patient has history of hypertension. He was admitted for a GI bleed and received 2 units of blood. And the last hematocrit 2 hours ago was 31. His vital signs now are 90/50, and the pulse rate is 120. So that's very concerning. And you will say your assessment, I think he got an active bleed and we can rule out an MI, but we don't have a troponin or a recent hemoglobin and hematocrit. And can you please, I'd like to get an EKG in labs, and can you please see this patient immediately? So that's how you will frame your SBAR. So we ask the student, whatever platform they're using, that to use this SBAR when they're giving report to the clinical instructor or to their fellow student. Another tool that we require the students is the med reconciliation. No, med reconciliation is basically done by our healthcare providers or our doctors. And so imagine these patients, they have tons of medications are being ordered. Like for example, this a 62-year-old with extensive heart history, and he is taking aspirin, colchicine, digoxin, Lasix, magnesium, metoprolol, nitroglycerin, and Cialis. And that's a lot of medication. The doctors, what they do, or the provider will do, they will do a med reconciliation. So what interactions if these patients are taking these meds, what kind of reaction they will get from taking all this meds. So that's a med reconciliation. But I got this idea from Dr. Jerry Altmiller. She is a professor from the College of New Jersey, and how to teach this to students. I remember when I was a student back in a long time ago, that what we do is we write the medicine, like the generic name, the classification, the rationale, and the nursing interaction and mechanism of action, and so on and so forth. We write it down and then we submit it to our professor. And at the end of the day, that's what I did. I submitted a paper, and sometimes I don't remember what I wrote. However, if we do a med reconciliation with education, for example, Bob has 3 medications that has interaction and that needs education. For example, Bob is taking metoprolol and nitroglycerin and Cialis. And you all know that this medication can drop the blood pressure. So if the patients drop blood pressure, this patient is high risk for fall. So maybe your education will be say, hey, Bob, before you get out of bed, just sit at the edge of the bed and make sure you don't get up so that you don't fall. So this kind of education that we teach our student to say, like I force my student, or I encourage my student, not force, but encourage my student to go at the bedside, sit by the patient, and educate the patient about their medication. So they are, and also educate their own patient about the interaction of this medication. So not only they are forced to communicate with their patient, they are also forced to learn the medication themselves. So I think that's a powerful tool that we give our students, the med reconciliation. What did we learn about this online clinical? I know we learned so much, but 3 things that we learned that I want to share with you, that those schools were existing combined face-to-face and online clinical prior to lockdown had easier transition to online clinical. And this is supported by study by Dr. Terry and her cohort in 2017. And I think they did a study globally, and some of this study were done in Philippines, that those who have face-to-face instruction combined with online resources improve retention of clinical skills. So if you have both combination of online and on-ground clinical, that is powerful tool for your student. The number 2 that we learn is from this pandemic is super users are lifesavers. So what we mean by super users, and we use this a lot here in the United States, but super users are those people who are technologically very savvy. So they are the point person. So at this time, we are learning different apps or different platforms. There's the Swift River, there is the Neighborhood, and there is I'm in charge of the ExamSoft. So what I do is I learn the platform, and I become the point person. I will kind of train the trainer myself. So the super users are a good resource for whatever platform that you are using. So especially we have in here in the United States, we have what we call part-timers. Our clinical instructors are usually part-timers. So we can direct them to say if they want to use the Swift River, is we have a point person for them to train them the Swift River. The other thing that I learned is creativity and communication. I have never seen my email exploded with email from students and from everywhere, from the school, from everywhere. So I can imagine how the student on the student side, they're also getting this email, and some of them, they don't even know how to respond them because they all look alike. So what I told my student, if you receive an email from me and it says ASAP response needed, that is very important email. So you have to how to you communicate with your students, because this email, and they just go to the email and sometimes they don't even open it because there are just so many emails that they're receiving in a day. And the same way with us. just one more slide, is in our academic universe, the center of our universe is our students. And every help that they need, we should provide. And also, I've learned the same way our clinical faculty, they need also help, the same way as our students. That's all I have. These are the resources that I use, references, and thank you so much for listening to me, and I hope you have a great day.
Thank you very much. That was that was our last panelist for this morning. We have from the United States of America, Professor Bienvenido Tabuso Jr. Thank you, Sir Bien. At this juncture, we will now have the open forum. So since much of the questions were already answered by our speakers and our panelists, allow me to read the question coming from our Facebook. And this is addressed to Dr. Benner. It says, "It is a pleasure to witness a legend inside the nursing profession. My question is, how would the nursing field view us, graduates of nursing, under the current virtual scheme? I do assume and recognize that there may be some kind of skepticism that may be present from seniors in the field, as these graduates may not be as clinically exposed unlike those before us. What is your advice for future nurses who may encounter this kind of qualm at the start of their careers?" May we have Dr. Benner?
Yes, I think, I think there really are some problems. There have been a couple of studies showing that the curtailment of clinical learning or access to clinical sites and the sort of rapid online learning startup have made current graduates less practice ready. I think you're entering in very difficult circumstances. My recommendation is that you find really good nurse residency programs that will support you in that school to work transition, because of the difficulties of having adequate clinical learning sites during time of COVID. But don't worry, we have an incredible nursing shortage. We need you desperately. And I'm encouraging all my colleagues to be as kind and helpful as possible, because if ever we needed new recruits, it's now.
Okay, thank you, Dr. Benner. Another question would be coming from Kylie Elisha Gatmaitan. What can you tell to us student nurses who are feeling unmotivated due to the limitations that online classes are giving, which somewhat hinders us to fully experience the learning process of becoming a nurse?
Oh, well, I encourage you to develop your own small, passionate learning groups among student colleagues and friends, and then get assistance and buy-in from professors to work with you. If you're, it can seem like it's hard to motivate yourself when there's a lot of barriers, but just when there are barriers or when you need to motivate yourself. So I think supporting one another and encouraging one another in learning, there's lots of evidence that shows that some of the best teaching learning occurs between student to student. And also you can always enlist a willing professor to work with you when your enthusiasm is bright and you're and maybe you serve cookies, I don't know. But I do think these are very difficult times in which to be entering nursing, but yet it is, as I just said, a time when we never needed recruits more. So welcome, welcome. And I wish you meet nothing but kindness from your colleagues in nursing.
Thank you, Dr. Benner. Just one last question for the interest of time. And this one is very interesting. What advice can you give to nursing students who wants to become a nursing theorist like you?
Oh, well, read. But the major learning ground you have is nursing practice itself. What started me off thinking, one of the first books I wrote was The Primacy of Caring, was because at the time I wrote that, stress and coping was in its heyday of exploration and scholarship. But all the stress and coping theorists always had advice about distancing, problem-focused coping, detachment, and the Cartesian view of, which is outdated now, but of the person standing over against and separate from an objective world. That was a very poor starting place for a practice which focuses on caring practices and caring relationships and connection and skills of involvement. You can't become an expert nurse without really having exquisite skills of involvement. So I think learning directly from practice and then trying to give good language to what you learn from common humanity, from suffering, from courage, from directly from your patients, can start you quickly on the road to becoming a theorist.
Thank you very much for sharing your knowledge, and more than knowledge, thank you for sharing your wisdom to us, Dr. Patricia Benner. And this concludes our open forum. And just an announcement for those schools who would like to, or who are slated to have their face-to-face classes. It was mentioned during the visit of the Commission on Higher Education in Our Lady of Fatima University that all students and faculty who will undergo the limited face-to-face classes should at least receive 1 dose of COVID-19 vaccine. So again, this was mentioned by the Commission on Higher Education during their visit in Our Lady of Fatima University. Truly, this is an engaging open forum as we had valuable inputs, most especially in this challenging time. Thank you to our dear attendees for your active participation, and to show our gratitude to our speakers and panelists, the Our Lady of Fatima University would like to give them our recognition. To award the certificate to Dr. Benner, may I invite Dr. Maria Louisa Uwayan.
Yes. To our dear keynote speaker, the Our Lady of Fatima University presents the certificate of appreciation to Dr. Patricia Benner for being the keynote speaker during the first International Nursing Conference with the theme Clinical Competency Development via Online Instruction During Pandemic, given this 27th day of May 2021. Signed, yours truly, Dean College of Nursing, the Vice President for Academic Affairs, Dr. Heraclio D. Lagrada, and the University President, Dr. Caroline Marian S. Enriquez. Congratulations, Dr. Benner.
Thank you very much. I'm really honored.
And to award the certificate to Dr. Ronda Los, may I invite Dean Nelia Capulong.
Wait, okay. This certificate of appreciation is awarded to Dr. Ronda Los, PhD RN, for being the speaker on the topic Alternative Platform on the Online Clinical Competency during the first International National Conference with Dr. Patricia Benner with the theme Clinical Competency Development via Online Instruction During Pandemic, given this 27th day of May, 2021. Signed by Maria Louisa Uwayan, Dean of the College of Nursing, Dr. Heraclio Lagrada, Vice President for Academic Affairs, and Dr. Caroline Marian Enriquez, University President.
And to award a certificate to our panelists, may I invite Professor Francis Vasquez.
Hello, good morning again. So this certificate of appreciation is awarded to Professor Jenica Ana A. Rivero, Dr. Ferdinand Gonzalez, and Professor Bienvenido Tabuso for being a panelist on best practices on online instruction around the globe. During the first International Nursing Conference with Dr. Patricia Benner with the theme Clinical Competency Development via Online Instruction During Pandemic, giving this 27th day of May, 2021. Signed by Dr. Louisa Uwayan, the College Dean, Dr. Heracleo Lagrada, our Vice President for Academic Affairs, and Dr. Caroline Marian Enriquez, our University President. Thank you very much and congratulations to all.
Thank you so much. It's an honor to be here.
Again, our utmost gratitude to our speakers and to our panelists. Despite the time differences, they generously show their support for this international conference. Mabuhay at maraming salamat po. For our evaluation and post-test, the link and the QR code is flashed in your screen. Certificate of attendance will be generated once you completed the evaluation in our post-test. You might want to take a screenshot so you can access our evaluation activities. And to give the closing remarks, may I call on one of the program heads. Let us all welcome Dr. Potenciana Maroma.
So good morning, everyone. It has been a productive and wonderful day for all of us. We are so lucky and fortunate to have with us today the important personalities and experts in nursing education, locally and globally, who graced the first International Nursing Conference hosted by Our Lady of Fatima University with the theme Clinical Competency Development via Online Instruction During the Pandemic. Dean Maria Luisa T. Uwayan talks about resilience in an institution this COVID-19 pandemic. She said, COVID-19 pandemic made us vulnerable, susceptible, and fragile, but brought us in our humanness, our being a human with a heart. She introduced the nursing academic pantries and Dean's toolkit that, according to her, we should share what we know and what we have, magbahagi, and we should empathize and help others with an open heart, makipagdamayan. In our fight with the COVID-19 pandemic, we should not separate the winner from the loser and determine who is successful from the failure. Instead, we should hold on together, and with perseverance, we rise to the top together as one. Because resiliency in an academic institution lies in its robustness, agility, and integrity, as explained by Dean Uwayan. The coronavirus pandemic in year 2020 brought so much significant impact on the delivery of educational instruction, one of which is the relevant discipline-related supervised work experience that has intentional learning outcomes and goals for students. Traditionally, internship or practicum on RLE has been conducted in person at an organization's workplace. In unexpected circumstances like COVID-19 crisis, internship may be done using varied platforms. The Our Lady of Fatima University, true to its vision mission of improving management, has embarked on various strategic plans to ensure that the needed competencies of the students, especially graduating students, will be achieved. There are no other options but to really go flexible in the mode of instructional and skill instruction. This has been the focus of discussion by Professor Francis Vasquez, Program Head of Our Lady of Fatima University College of Nursing, on preparing the university for flexible learning experience. Since May of June last year, 2020, the following were accomplished. Series of meetings were done by Our Lady of Fatima University MANCOM or Management Committee, including recalibration of different curricula, retrofitting of virtual laboratory and nursing arts lab, and establishment of health protocols. Zoom meetings and orientation with parents and students, planning of scheduled limited face-to-face activities. Also, COVID-19 training and rollout among faculty and students in collaboration with Project Hope and Assist. Series of training of faculty members on Canvas, or this is the learning management system being utilized by our university. Also, vaccination rollout for faculty and students. We are happy and proud to say that Our Lady of Fatima College of Nursing is very much ready for limited face-to-face learning to be done in virtual laboratory and at different nursing arts laboratory with standardized patients and high-fidelity mannequins as presented by Professor Francis Vasquez. Our keynote speaker is an expert and accomplished person in the field of nursing. Professor Dr. Patricia Benner discussed about nursing theory from novice to expert concept. This concept explains that nurses develop skills and understanding of patient care over time from a combination of a strong educational foundation and personal experiences. Dr. Benner proposed that a nurse could gain knowledge and skills without actually learning at Turing. She describes this as a nurse knowing how without knowing that. She further explains that the development of knowledge in fields such as nursing is made up of extension of knowledge through research and understanding through clinical experience. Dr. Benner identifies 5 levels of nursing experience: novice, advanced beginner, competent, proficient, and expert. These different levels of skill show changes in the 3 aspects of skill performance: movement from relying on abstract principles to using past experiences to guide actions, change in the learner's perception of situations as whole parts rather than separate pieces, a passage from detached observer to an involved performer, engaged in the situation rather than simply outside of it. The levels reflect movement from reliance on past principles to the use of past experiences and change in the perception of situation as a complete whole with certain relevant parts. Each step builds on the previous step as principles are refined and expanded by experience and clinical expertise. Dr. Benner also emphasized the different teaching learning strategies from novice to advanced beginner, senior, and new graduate, as well as innovative approaches to teaching clinical reasoning utilizing the nursing process. She also emphasized the application of experiential learning. Students are graded accordingly how they perform in different modules presented to them using high-fidelity mannequins, which can be set to different medical surgical conditions where students apply critical thinking and reasoning. They perform different nursing procedures, including pharmacology, while providing quality and safe nursing care. If, in the contrary, error was committed or sentinel event happened, immediate feedback is given. That is a fantastic presentation by Dr. Benner and Dr. Kyriakidis. Alternative platform for online clinical competency was the focus of discussion of Dr. Rhonda Laus, who is the Director of Nursing Program from Lecturio, USA. Lecturio offers comprehensive video library with a short, concise, and easy-to-follow videos by practicing nursing experts, simplifying even the most complex topics for the students. Students can study anytime, anywhere. It also gives smart recall quiz as well as end practice exams, also given by nursing experts with detailed explanations, book references, and link videos. Dr. Laus also said to encourage Our Lady of Fatima nursing students to accept personal responsibility for their learning. Dr. Laus also said that Lecturio prepared several videos on the performance of different procedures. Today, she focused on the procedure of IV insertion, where students can watch anytime, over and over again, take notes, and at the end, ask them what they have learned. Are they competent or not to do it later? While the second part of the conference was the panel discussion by 3 panelists who shared their best practices on online instruction. The first panelist is Professor Jenica Ana Rivero, a faculty in the College of Nursing, Southern Institute of Technology, New Zealand. Professor Rivero said that COVID-19 disrupted nursing education, but could be a catalyst for transformation. Strategies they employed in their university after pandemic are mass education, virtual classes, reflection, intentional practice of communication, and debriefing. She focused on mass education, where physical assessment was done collaboratively and virtually. This allowed the students to be more confident, improve communication skills, students have active engagement, and it enhances cooperative learning. HoloLens is another strategy which also enhances students' motivation and engagement with learning. Good thing they do after the pandemic is debriefing, wherein they assess if students still learn and acquire the learning competencies expected of them. This debriefing identify the learning gaps, obtain understanding with depth, and discussion of practical applications. Finally, Ms. Rivero said that COVID-19 is a transformative disruption which has effect among educator, faculty, administration, and accreditors. The second panelist is Dr. Ferdinand Gonzalez, a consultant specialist in the University of Hale, Kingdom of Saudi Arabia. He said that they group students into 2. The first group will do face-to-face instruction, and the second group will use Blackboard LMS while absorbing the health protocols. Dr. Gonzalez placed emphasis on multi-station clinical skills assessment method that is based on objective testing and direct observation of student performance. Studies have shown that this is a valid method to assess clinical skills and competence that are fundamental in the practice of nursing. They utilize the modified OSCE or objective structured clinical exam, which they also use standardized patient as well as high fidelity patient simulator mannequins, which will portray medical conditions. Competency skills are assessed in details, including interpretation and analysis of diagnostic test results, drug studies, rationale, nursing interventions, communication skills, and professionalism. Students pass through different stations like Station 1 is about nursing assessment. Station 2 is about nursing diagnosis and planning. Station 3, implementation, wherein the students perform the different procedures. This is the actual student demonstration and on different procedures, and they are graded using rubrics. And the fourth station is the evaluation and documentation using FDAR. The third panelist is Professor Bienvenido Tabuso Jr., an adjunct clinical faculty, Yale University School of Nursing, USA. He discussed the challenges of online clinical experience. He identified online platforms that enhance students' learning, critical thinking, and clinical skills. Among these are Unfolding Case Studies, My Neighborhood Person, ATI or Assessment Technologies Institute, Sweep River or Virtual Clinicals. He focused on video scenarios wherein students watch the video and read the video questions and answer the questions using SBAR templates or format. SBAR stands for Situation, Background, Assessment, and Recommendation. Situation about writing the patient's name, problem. Background is about what's the admitting diagnosis, medical diagnosis, the brief history of treatment being given to the client. Assessment is about the vital signs and neurovital signs, as well as head-to-toe assessment. And recommendation for the doctors, whether to see patient, to transfer client to the ICU, wherein the students are really challenged and apply critical thinking and judgment. Students also do medication reconciliation. So before I end, Our Lady of Fatima University would like to express our heartfelt thanks and appreciation to our keynote speaker and panelists for sharing their experiences and precious time with us. To the administration of Our Lady of Fatima University, headed by Dr. Caroline Enriquez, we would like to express our deepest gratitude for your continuous effort to the College of Nursing. To all the participants and attendees, our nurses in the nursing service and nursing education in the Philippines and abroad, to all our nursing students from different campuses, thank you so much. You serve as an inspiration to do better and continue providing quality education despite the pandemic and fulfill our vision and mission of improving management. To our organizing committee, headed by Dean Maria Louisa Uwayan, Mr. Francis Vasquez, your efforts are all appreciated and recognized. To Dean Elia Capulong, Dr. Michael Joseph Dino, who is the overall head of technical committee, thank you so much. And above all, we thank the Lord Almighty for making this event a success. Thank you very much, and may God bless us all.
Thank you very much, our program head, Dr. Potenciana Maroma. I would like to end this conference with a quote from Yasmin Magahed. She said, "Resilience is very different than being numb. Resilience means you experience, you feel, you fail, you hurt, you fall, but you keep going." From all of us here in Our Lady of Fatima University, Philippines, thank you very much, and we hope to see you all soon. And as we say here in the university, rise to the top. God bless everyone, and enjoy the rest of the day.